Not even that. It was just $30 a month for all three.
They're wrong, but
Yeah.
I said $1,000 for $3.
Yeah.
And
What a steal.
Debbie thought it was a little high.
I got flag football practice Friday night. It's like, always. That's sweet. That's how my girls are with their grandma too. Oh, same way. They love my mom. They just want to be with her all the time. There's been some unfortunate circumstances with other grandparents.
Yep. That's all you do is just click on us.
What's best?
And then it's active. Yep. Good to go. Yep. It's in the paramedic refresher.
Yeah.
Save it to your phone. And then go to your photos and then open it up.
So funny. She's used to having like the spandex leggings and stuff. We have to do that when they wear like dresses or skirts because I'm like, they have no sense of like sitting appropriately. I'm like, guys. Well, she's also like in gymnastics. Oh, yeah. Do the cartwheels and I know. And I think she's 8. So yeah. Aaron's trying to get her to be a little bit more aware. Yeah. Like, it's okay. It's sweet when they. I'm going to let you introduce yourself. Okay. I'm Susanna Weir. I work over at the Birthing Center. I'm a lead nurse and our unit educator over there. I've been a labor nurse for going on 9 years now. I am not a huge public speaker, so please bear with me with all this. Usually my education is in much smaller groups. So I'm just going to kind of go over. Have you guys all had a class on OB before? This is people deliver in the car and all the things recently. A lot of home births that have come in that, yeah, all the things. Okay, so just going to the basics. So you have a patient that calls whether they think they're having a baby or they're calling for high blood pressure, whatever it is. Just make sure if she's in labor and she thinks she's getting ready to deliver, just make sure that you always ask for consent. That's the big thing that we've been trying to talk to all of our nurses to. I know that we get very in, like, this is our job, and especially the nurses in the birthing center will come in and be like, okay, we're going to check your cervix, and don't say anything about, hey, is it okay if I check your cervix? Is it okay if I look and see if that, in your guys' instance, if there's a baby coming out? So just make sure you always ask the patient. And then if they feel like they're delivering, looking but probably not trying to check a cervix would be the best case, because sometimes you can tell if the baby is coming out, but I don't think there's ever any need for you guys to check a cervix or anything like that, especially if there is a lot of bleeding. Like if she's getting ready to deliver, a little bit of bleeding, what we call bloody show, is normal, but a significant amount of bleeding is not normal, and she could have a placenta previa, she could be abrupting, something like that. So making sure nothing is inserted would be the best. Normal changes in pregnant patients. Sorry, you guys are going to see my notes on the side, but blood pressure with patients. It is normal for it to decline during pregnancy. But then usually towards the 3rd trimester, it'll come back up. A normal blood pressure for a pregnant patient should be anything 140/90 and below. If they get to 140/90 or above, we consider it gestational hypertension and possibly preeclampsia, but preeclampsia has to be diagnosed with other factors. But if you see, I know I talk to our ER nurses about this a lot as well. I feel like you guys see crazy high blood pressure. So a patient that comes in with a blood pressure of 160/110 doesn't seem concerning to you because you see people that have crazy high blood pressures. But 160/110 for a pregnant patient is severe hypertension. And that could be a mom that's going to be seizing. It could be a mom that's going to stroke. So that's a huge thing, is if you see a patient 140s/90s, we get concerned. 160/110, that's severe, and that's like a medical emergency. So just being sure that we're passing that on and we're taking that very seriously, because it might not mean something for someone who's not pregnant, but for someone that is pregnant, that's a big deal.
How far along would that be a concern with them in a pregnancy?
So gestational hypertension is usually after 20 weeks.
After 20.
Yeah. Preeclampsia and gestational hypertension, typically it's later in pregnancy, so I would say 30 weeks and below. But we have some severe preeclamptics that will come in 23, 24 weeks with these crazy high blood pressures. If they're preeclamptic that early in pregnancy, typically CRH will go ahead and send them up to maternal fetal medicine for closer watching them closely. If it's before 20 weeks and they're having high blood pressures, it's probably more chronic. It's probably not gestational. But if they're gestational hypertensive, it moves into preeclampsia once their protein creatinine ratio gets higher, once they start having other issues like headaches, upper abdominal pain, vision changes, things like that. So there's other diagnostic things that I'll get into with preeclampsia. But just know if you see those high blood pressures, that's a big deal. But seeing blood pressures that are a little low, especially early on, is not super concerning, as long as mom feels okay.
Is there something that you guys can give, or somebody can give, to help the blood pressure come down without harming the fetus?
Yeah. So typically we will do labetalol is our kind of the gold standard, is what we typically give. If they don't have an IV, sometimes we'll give Procardia, just because they can take that oral. And like if we have a patient come in via triage and they have this crazy high blood pressure, and they don't have IV access yet, we'll go ahead and give them Procardia until we can get IV access, and then give them labetalol. And I can send to you, to Tammy, what our labetalol protocol looks like. Not that you guys would be going through all of that, but just so you can kind of see that what we do. We usually give labetalol up to 80 milligrams, and then we'll switch over to hydralazine. And some people don't react well to labetalol, it just doesn't work as well. But then hydralazine works, so it just kind of depends. But those are the things we give. If we have a patient that comes in with these super high blood pressures, we usually start them on magnesium as well.
So, quick question in regards to. So I have a student who reached out to me. She was in one of my EMT classes prior to, and so she messaged me the other day, and she was telling me, she was like, "I'm sorry to bother you." She said that she had her baby on Sunday, and then she said that anytime that she was laying on her left side, flat on her back, blah, 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 she felt this like squeezing and pressure in her chest. And so I told her, I said, I personally would go get checked, you know what I mean? But then she said she went to her OB yesterday and they didn't seem too concerned. And I was like, well, that doesn't sound normal. So then she did message me and said she wound up going to the ER and they diagnosed her with preeclampsia after the fact. So with her feeling that prior to, was that an undiagnosed preeclampsia and then it just continued to afterwards? Or is that something that's normally that happens after childbirth also?
So it can happen after childbirth also. If it was something that was undiagnosed, I'd have to see like what her pressures and her lab values and stuff.
Because I never heard of preeclampsia.
Yes.
After birth,
Yes,
so.
and so yeah, they can be completely fine, normative their entire pregnancy, and then it kicks in postpartum. So that's why I've worked a lot with our ER as far as when they come in, asking them, have you delivered a baby in the last 6 weeks? And if so, it brings up a whole nother list of questions because yes, you can start getting preeclampsia after.
187 over 100.
Yeah, that's a little high. And so yeah, we have postpartum readmits. I wouldn't say a whole lot, but I mean, somewhat frequently, we'll have postpartum readmits for preeclampsia, and they will come in. We'll treat them the same way as if they were pregnant. So they'll go through the beta-lol protocol. They'll go on magnesium. Magnesium for us is not. It does lower the blood pressure. That's not really what we're trying to do with it. It's to prevent seizures. So, but yeah, you'll see usually they'll be on magnesium for 24-ish hours until, yeah.
She was messaging me from the hospital.
Yeah.
Actually.
Yeah, so those patients come back up to OB and we just do the same thing. But yeah, they'll usually be on mag for 24 hours and then until we can kind of get their medication under control. Some patients, like if they were preeclamptic before and we know that they're still kind of having these high blood pressures, they'll go home on something until their 6-week follow-up. So, but yeah, that's normal. We actually did a drill with the ER, gosh, it's been a year or so ago.
I was just curious. I didn't know if maybe like with everything going on, she typed in preeclampsia and meant like, I don't know, was it postclamp? You know what I mean? Like,
Yeah.
what, you know,
No, so
I had never heard of it after.
yeah, so preeclampsia is actually, which we'll talk, I mean, we maybe have touched on it enough, but preeclampsia is actually the pre part is before they seize. So once they start seizing, that's eclampsia. Yeah. So yeah, it's, hopefully they don't seize. We don't love that, but it happens. Also important to know that these patients will have an increased amount of blood volume just because they have enough blood for them and baby. So if they are hemorrhaging, if they've delivered, if they're abrupting, something like that, and they're bleeding, just know that a mom is going to lose a lot of blood before she starts showing signs of shock, usually around 1,500. So when we have deliveries, a vaginal delivery, we start getting worried around 500 of blood loss. Anything before that's normal. C-section, it's 1,000. So what our stage 1 hemorrhage is anything for vaginal and C-section deliveries is anything over 1,000. So it's not uncommon for patients to lose 1,000, 1,500 of blood. They might get iron or something like that, but just know they're not going to show signs of shock until they start getting a little bit above 1,500. Okay. All right. I feel like we all probably know what labor is, cyclical contractions. Sometimes it's hard to tell if it is real labor or if it is Braxton Hicks, but we take everything seriously until we rule it out. How we diagnose it in the birthing center is if they come in and they're contracting, we'll put them on the monitor, baby on the monitor. We'll check their cervix, check them 2 hours later. If they've made change, then we go ahead and admit them. Or if they're like 2 hours later, they still haven't made change, but they're really acting like they're in a lot of pain, sometimes we'll give them a little bit longer. But the only true way to diagnose between Braxton Hicks and real labor is if they're making cervical change. Sometimes it's early labor. If the patients come in and it's Braxton Hicks, sometimes we'll give them fluid, we'll give them Tylenol. If it's true labor, that won't knock that out, but if it is false labor, it will help. Especially as we're getting into the summer, we always say around fair time is when everyone decides they're gonna start contracting. Just because people get out, they get hot, they get dehydrated, and then they start contracting. So that will cause uterine irritability. And it can look like true labor, but sometimes they just need a bag of fluid and to sit down for a little bit. So, yeah, usually around fair time, everybody starts coming in. Okay. And this we kind of went through actually delivering a baby. I don't know how many of you guys have actually delivered. If they're delivering in the truck, usually it's just an easy, they just slide right out. It's probably not their first kiddo. If you're going to have things like a dystocia or it's not going to usually just slide right out. So if in that instance, you get them in the truck, they're starting to deliver, I always say put one hand above, one hand below, guide the baby down because you want to release that top shoulder and then up to release the back shoulder. And I'll go over shoulder dystocia here in a second just so you can see why we go down and up. Once baby delivers, dry it off, put it skin to skin with mom. That's the best way to keep baby warm. I know a lot of times we want to wrap baby in a bunch of blankets and put it somewhere else. If you put baby skin to skin with mom, wrap both of them in a blanket, mom's body temperature, that's the best way to keep baby's temperatures up. Once baby delivers, you can clamp the cord. A lot of times I feel like you guys bring them in and then we deliver the placenta there, which is totally normal. So don't worry about putting any traction on the placenta or anything like that. We don't start getting worried till the placenta, if like 30 minutes. If it's not out, then we're like, oh, maybe we need to do something to try and help it out. Yeah, what's up?
So one issue is kind of probably a big issue for us, and I would say it's an issue for all of EMS. We don't like free-floating bodies in the ambulance.
Yeah.
So baby needs to be secured somehow. So usually that equals out to baby goes in another ambulance or baby goes in a Pediatrics, which is our little securing device, but
Okay.
we really don't like bodies being.
Yeah, that makes sense. That makes sense.
I mean, if you see it, that's why.
Yeah, no, that makes total sense because I wouldn't have thought of that from my side that like, yeah, you probably should have something to hold it down. Yeah, so no one's going to be like, oh my gosh, why didn't you put the baby skin to skin? But yeah, that makes sense.
We'll be there quick anyway.
Roll over,
Yeah.
baby ejected, problem.
Yeah, right. Yeah, that's probably not a great thing. So that makes sense. I can't remember, gosh, it was when I was on night shift, so it's been quite some time ago, but we had a patient come in and she had delivered at home, EMS had delivered, and this sweet little EMT came in and he's like, well, I tried it, I didn't know if the baby needed to latch, and I'm like, oh God, you don't have to do that, that's okay. It was so sweet though, because he was trying, so I mean, it was very nice. But yeah, I was like, oh, you don't have to latch the baby, that's okay.
Is the baby trying to latch on the ENT or?
Yeah, I don't think so. I was just like, that's so sweet. Okay, when the baby delivers, so you have baby's out, dry and stem, clearing the mouth and then the nose. So that first breath, that baby's lungs are full of fluid. So that first breath that they take, open all of those alveoli in their lungs. So trying to clear that fluid out so that when they take a big deep breath, they're not inhaling a whole bunch of fluid is helpful. Always the mouth and the nose with just a bulb syringe, nothing like no crazy suction or anything like that. The stimulating that we do is to try and get the baby to cry. So whenever they cry, that's when they take that first big breath of air. And it's actually, which I could geek out about this all day long, but actually that first breath that they take when their lungs open, that's actually their entire circulatory switches. So when the baby has two arteries in one vein and the way that the blood flow in a baby is completely opposite of a regular person, and so whenever they take that first big breath, that closes a duct in their heart that switches their entire circulatory system over. So it's pretty cool, like when it's nuts, like all of the things that happen within that first few minutes, it's crazy. I'm like, yeah, so I won't geek out on that, but it is pretty cool. Okay, I kind of went over that. Dry and stimulate. If you are clamping the cord, just make sure, I would leave a little bit of length on it. Don't put it straight up against the belly button. I would leave like 4 to 5 inches maybe. I know that sounds crazy, but if it was an early kid or a kid that we're going to have to resuscitate when we get there, sometimes we'll do what's called an umbilical line. And if the cord is too short, it makes it really hard for us to try and get that. So if you clamp out and then we have to put an umbilical line in, we'll cut down here and put it in. So it's just like an IV, but that's the easiest way to get an IV for babies is to go through, because there are 2 arteries and a vein right there. So if we're coding a kid and have to give epi or give anything like that, we'll go through the umbilical vein. So cutting that a little bit longer so that we can use that is super duper helpful. we can always cut it down. If it looks excessively long, we can always cut it. It's not that big of a deal. We'd rather have too much than not enough. Okay. Any questions on that, like normal deliveries? Anything? Okay. All right, so now we're going to go through all of the things that can go wrong, which is so many. Miscarriage. So anything that is less than 20 weeks is what we consider a miscarriage. Sometimes we know why it happens, sometimes we do not. Main thing, if you have someone that's being transported to ED for a miscarriage, if they are less than 20 weeks, they will be seen in the ED almost always. We get some that are like 18, 19 that we'll bring up to the birthing center and deliver, especially if we have to do a DNC or something like that. But typically they're going to be seen in the ED. What they're going to want to monitor is bleeding to make sure that everything is passed, make sure that there is no tissue still in there, because if there is, they will continue to bleed. So just monitoring their bleeding. If they call you for contractions and they end up passing the baby in the EMT or in the truck, I would just go ahead and wrap it in a blanket, put it to the side. Sometimes those moms will want to see the baby afterwards. So I think it's really important that we remember that even if it's an early loss, that this is still their baby. And so sometimes they don't want to see it, sometimes they do. So treating it like a human being, putting it to the side. We have the ED call us a lot for different bereavement things that we can come down and do for them. If it's early like that, a lot of times we can't do like some of the memorabilia, but we do have things on the birthing center to help with moms who are having a loss. So just making sure that that baby still goes with mom into the ER is super important. And then monitoring bleeding. We talked a lot about preeclampsia, the 160/110. Big things that you guys can do, watch for this is headaches. They will have a really bad headache that's not relieved by Tylenol. They will have vision changes, so like seeing spots, things like that. Upper quadrant pain, usually right upper quadrant pain, so it's their liver that's they're complaining of. And then sometimes shortness of breath, things like that. It's pretty rare that a mom like strokes from preeclampsia, but it can, I'll just knock on some wood, it can happen. So they do have these crazy high blood pressures. It is a multi-system issue. We don't really know what causes it. There are some risk factors, but we don't know why some people get it and some people don't. We can kind of guesstimate, but there's no real reason. But it does affect a lot of systems. So it affects their blood pressure, it affects their kidneys, it affects their liver, it affects all of the things. Things you can help for with this is getting IV access early on, which I know is pretty standard for you guys to get IV, but we're gonna wanna get blood pressure meds in them pretty quickly. So if they already have IV access, that is hugely helpful. And then just making sure that do you guys have seizure precautions on the truck, like patients you think might seize?
First set.
Okay. Okay. So just maybe making sure you have that on hand, because it is not uncommon that they seize. A lot of times their blood pressure will get high and they'll start seizing. If they are pregnant, still pregnant, so if it's postpartum preeclampsia and they're seizing, it's normal seizure precautions. If they're pregnant and they are seizing, just making sure that you're kind of turning them, I know you don't want to turn them all the way to their left, but kind of maybe tilting their hip just a little bit to the left to make sure that baby is still getting blood flow, still getting oxygen would be really helpful as well. And then yes, it becomes eclampsia when they start seizing. Okay, preterm labor, cervical contractions and contractions and cervical change before 37 weeks. This is a huge deal because a lot of times if they are super early, the biggest thing we're worrying about is baby. Is baby gonna be able to breathe? Is baby gonna be able to keep temps up? Things like that. The reason people go into preterm labor, there's all different reasons. A lot of times we think infections, so any kind of STIs, UTIs, things like that can lead to preterm labor. Also dehydration. I talk about a lot of people having Braxton Hicks around the fair time, but it can lead to actual true preterm labor. We also give Procardia for this, which is kind of funny. We use it for blood pressures, but we also use it for preterm labor. So you'll see some moms who come in and we stop the preterm labor, and then they're on Procardia until about 36, 37 weeks, until we're like, okay, well, if they deliver now, it's no big deal. But that will kind of keep them from contracting. Important to ask any kind of medical history, obstetric history. Do they have a history of preterm labor? Is this their first baby? Have they had a history of any kind of infections or anything like that? And then just making sure they get to the birthing center super fast. We'll talk about the baby stuff here in a second, but for mom, you just want to try and get them to us. So this is when baby is not head down. There's lots of different kinds of breech. Sometimes they're frank breech where both legs are up, and we don't typically deliver breech. It's happened, but it's not common, and breech babies probably are not sliding out. So that's hopefully not something you guys have to worry about. But if there is a baby delivering that's breech, just making sure that you just try and guide out as much as possible, and then making sure the shoulders get out and then the head. You can also see footling breech. That's, I feel like, more common when you go to check a cervix or you go to look and then there's a foot hanging out. That's, it happens as well. Typically, if they're breech and we get them to us in early enough, we'll just go ahead and do a C-section. We don't typically deliver, but if they're complete, baby's already coming out, then we just do what we got to do. But there is all different kinds of malpresentation. Sometimes you see hands. Like I've had a patient that came in that was a quick delivery, and the baby grabbed my hand, and I was like, that's weird. That's not something I think is supposed to happen. But I go up there to see like what she's dilated, and a little baby grabs my finger, and I was like, well, that's not normal, but it's fine. Okay. So shoulder dystocia. I did bring my pelvis for this because I feel like it makes it easier, and my daughter's baby doll, because I feel like it's easier to see what is happening in a shoulder dystocia. So this is, if they're delivering in the truck, hopefully this does not happen, but I want you guys to kind of know what you need to do in that instance. So a shoulder dystocia is, baby's head is coming out. The widest part of a baby is their shoulders. So shoulder gets stuck behind the pubic bone and baby is not coming out. If you think they're delivering and you're seeing the head, what we call turtling, so head comes out and then after that contraction's over, head comes right back up against the perineum, that's probably a sign that their shoulder is stuck and they're kind of doing like that, if that makes sense. So this is where the shoulder is stuck right here. Typically, just laying mom completely flat and bringing her knees straight up. It's called McRoberts maneuver. That will typically relieve that because it will open this area up for the baby's shoulder to come straight through. If we do that and it is still not coming, the next thing you can do is what we call suprapubic pressure. This takes a lot of hands here. Okay, so baby's shoulder is stuck. Suprapubic pressure is where you are taking a fist and you are pressing down on baby's shoulder to make sure you're trying to taco the shoulders, if that makes sense. So pay attention to which side baby is facing, because if we say baby's facing this way and the person on this side is doing suprapubic pressure, you are actually making it wider. And that's not what we're trying to do. If you can see, if you're on the side, then you see the back of the baby's head, that's the side that you need suprapubic pressure. So you are pushing down on the shoulders and tacoing it in. A lot of times you will feel it pop, and that's okay. Kids with shoulder dystocias, it's not uncommon for them to have a broken clavicle. That's okay, babies heal really fast. We'd rather have them have a broken clavicle than not be breathing. So yeah, so just make sure that you're pushing down, you'll feel it pop, and a lot of times baby will just deliver past that. Once baby delivers, you can kind of feel their clavicles. If it's broken, it kind of feels like a, I don't even know how to describe it, kind of crunchy. It sounds gross, but a lot of times what we'll do with that, I mean, there's nothing like different that we would do with that aside from we would sometimes like safety pin their little arm like that, but it heals very quickly. But if they're not delivering and they're stuck, that's really nerve-wracking. Other things we do in the hospitals for that is the docs will sometimes cut in a peds. They can go up and do what's called corkscrew maneuver, so they would push the baby up and turn it and try and deliver. Worst case scenario is if we've done all of the things and baby is still not, the shoulder dystocia is still not relieved, they will push baby back up and go for a C-section. I have never seen that happen, again, knock on wood, but if that was to happen and we were going for a C-section, we are probably not gonna have a live baby. It's probably just like a recovery type of thing. So, questions about shoulder dystocia? Sorry, that got really dark, but that's something that you guys, I mean, would possibly be common that y'all would see, was that the baby shoulder gets stuck. Okay.
And that can happen at any pregnancy, right?
Yeah.
Number 1, number 7, number.
Yep.
And it doesn't matter the size of the baby?
It can happen to any baby. It is more common if it's a big baby, and it's more common if it's their first baby. If it's their 7th, I was probably just sliding out. Let's be real. We're probably not going to have that issue. But first, second, it's more common for those. And then if you have a patient that is gestational diabetic that is uncontrolled, they'll sometimes have a big kid. Babies that are LGA, large for gestational age, it's more common with them just because they're bigger, their shoulders are wider. If they're post-8, so a patient that's coming in that's 40 and 5, it's a bigger kiddo than like a 37-weeker. We're probably not going to have that issue with early term. So just thinking, if baby's big, mom's pelvis is small, which a lot of times we'll have like if it's their first baby, sometimes they'll elect to be a primary C-section just for like a contracted pelvis. And then that's something that they would talk about with their physician. That's not something that, if they're delivering in the truck, hopefully it's not their first kiddo and it's not something that you guys have to worry about. But it can happen to anybody. So, but hopefully not on your 7th, because that's really unfortunate. Okay, cord prolapse. I also brought my placenta just so that you guys can kind of see what's happening with a cord prolapse. If you are not checking the cervix, most cord prolapses are just tied up against the baby's head. You're probably not going to see it unless you're checking their cervix, and I don't think you are. So we will see it a lot of times on the monitor. When we get baby on the monitor, we'll have big dips in the heart rate. The most common kind of prolapse is when it's just here on the side, and so it's getting squeezed here. However, it can happen that they're at home, the baby's not well engaged, their water breaks, and the cord comes first. So if you're going to look to see if there's a baby coming out and you see a cord coming out, which can happen, it's not super common, but you see the cord, that's when you're going to want to do some things to try and relieve that pressure on the cord. So this is how the baby gets all of its oxygen. So if their head is up against it and they're pressing down on it, that baby is not getting any oxygen. So that's when we see big dips in the heart rate. This cannot be delivered through, especially if it's hanging out to where you can see it. They are not vaginally delivering through that. We're going to be doing a C-section. Sometimes if it's like beside their head, we'll try, the doctor, not me, will try and push it back up there to deliver vaginally if they're like close enough to delivery, if it's not their first kiddo, that kind of stuff. But if it is like out and you can see it, then we're not delivering that way. So say the baby's, you see the cord right here, baby's head's right here, and you're like, oh crap, we have a prolapse. What you are going to do is take both fingers, just like you're doing a cervical exam. You will put one on either side of the cord, and you are pushing the baby's head off of the cord. Once you are in there, you're kind of in it for the long haul. So when we have cord prolapses, the last one that I had, I went to check her. She had ruptured at home. There's a cord. My hand is inserted vaginally, and I am in it until she delivers. So same thing with you guys. You guys see a cord, finger on either side, pressing baby off of the cord. You can also put the patient in Trendelenburg. That helps because your hand's going to get tired. So if anything you can do to help. So putting the patient in Trendelenburg, we'll sometimes give them something to make sure we stop contractions and stuff like that. But then you will ride the bed to the OR with that patient. I know. It sounds weird. I think I'm like, I love it because I'm just like an adrenaline junkie. So I love it when we have things like that. But yeah, I've seen where a physician found it before, the nurse had to go hand over hand to switch. So they might have you do that. But probably you'll be going to the OR with the patient. You're on the bed. You are under the drape. So you're getting real personal with this patient for quite some time. So you're holding baby off the cord, you're under the drape. Once the physician cuts and take the baby, then you can take your hand out and you're dismissed. So, yeah. Yeah. But it's...
One's out of service for an extended period.
I know. Yeah. But it's incredibly important because that is how the baby is getting their oxygen. When you are holding the baby off the cord, try to make sure your fingers are not on a funnel. So make sure it's on like a hard spot and you're pushing the baby up. You don't want to have your finger like right in their soft spot forever, or like on an eye or anything like that. I had one that was a shoulder one time. Their hand and their cord came through at the same time. So I had like one on either side. So whatever the presenting part is, just make sure you relieve that. Questions about prolapse? Okay. Okay, placenta previa, that is just where the placenta is completely or partially covering the cervix. So that's a lot of times when we say that a mom's coming in bleeding, we want to make sure that we don't check, because if she did have a placenta previa and you're checking, you're putting your fingers right through the placenta. So that's our reasoning for saying don't check if they're bleeding. Not that I think you guys are all just really dying to check a cervix, but if you are, don't do it if they're bleeding. Sometimes you'll have where a mom has a low-lying placenta early in pregnancy, and then as their uterus grows, it'll kind of go to the side, but yeah. Okay. It's also important to note that sometimes the bleeding, so we have what's called a vasa previa, so that's where, see on this placenta, the cord is attached right here in the middle. A vasa previa is where the cord is actually attached to the amniotic sac. So it's not here, and that leaves all of these blood vessels open. So if they rupture and they're bleeding, it's actually babies. It's baby's blood that you're seeing, not mom's. So that wouldn't be diagnosed until they delivered, but that's also a medical emergency. Uterine rupture. This is pretty rare, but I've seen it happen. This is a lot of times if you have a patient that calls in is severe pain, their abdomen is really tight. A lot of times it's not like a contraction, like cyclical. It is just constant pain. And if they, it's where their incision opens. So again, you're probably not gonna be able to diagnose that in the ambulance, but just know if they say, hey, this is my 4th baby, it'll be my 4th C-section, and they're probably gonna tell you like that calmly, and they're screaming in pain, it could be that their incision is rupturing. Also, with this, usually you'll see significant uterine bleeding. Mom will become tachycardic, hypotensive. Just make sure you're starting an IV, getting fluids started, because as soon as we get there, we're probably going straight to the OR from there. Another thing that can happen is what we call an abruption. So that's where placenta is attached to the side. It can be a complete abruption where the placenta comes all the way off, or it can be a partial abruption where it comes off a little bit or comes off in the middle. These moms, again, severe pain. It will not be cyclical. It'll be constant. Sometimes you see significant bleeding. If it's come all the way off or partially off, you'll see significant bleeding. But if it's a hidden abruption, that's where this middle part has detached. So it's hidden. So it is bleeding, but it's all attached in there. We won't know that till after we deliver. I actually had a girl come in via EMS. It's been maybe 4 years ago, and she was a twin. It was her 4th pregnancy, 4th C-section, and she had twins, and it was a uterine rupture and double abruption. So both placentas detached and her uterus ruptured. So she came in screaming in pain. We're like, we don't know what's going on. I check her cervix. She's like 1, but I can barely find it. And I'm like, that's weird. Like, she's not acting like she's 1 centimeter, but you see people that come in 1 centimeter acting like they're dying. And we get baby on the monitor and both heart rates are in the 50s. And so by the time that you guys brought her in to the time that both babies were delivered, I think was 8 minutes. And it was like we opened her up and both babies just slid out because they were both completely just in her abdomen. So it happens, common with twins, common with multiple C-sections. But yeah, you will feel that super rigid abdomen, significant pain. Another thing with the abruption is they are losing a lot of blood. So whether it's the uterine rupture or they're abrupting, they are losing blood. So making sure you're bolusing fluid, making sure you're getting that IV is hugely helpful. Questions about any of that? Okay, I feel like I talk really fast because I get nervous. So yeah.
PDAs, how do you catch those?
Patent
ductus arterial.
Oh, that's
I had one and they didn't find it till I was 58. They thought I was asthmatic.
Oh, really? So usually that is one of the pediatricians will catch that after delivery. A lot of times it's just like they'll hear it, like a murmur type thing. And then if they do that, then they'll get an echo. Yeah.
Years and years ago, they thought I had a murmur.
Yeah. So a lot of times we'll hear that. Usually they resolve on their own sometimes, but sometimes they don't, and then they end up having to have surgery. So.
I ended up having surgery.
Yeah. It's crazy how many, it's scary how many things can go wrong, and that's why I'm like, some of these patients who want to deliver at home and do it, which sounds great so if that's your thing, but there's so many things that can go wrong. So, you know. Okay. So uterine rupture, maternal cardiac arrest. Again, this can happen for a lot of different reasons. You would do CPR just like you would do CPR on a mom who is not pregnant. Only thing that is different is if the mom is still pregnant, you're wanting to move that baby off, like to the left uterine displacement. So you're wanting to move it off of all of those vessels. So she is still getting blood. So now you'll be doing regular CPR, but then you're going to have another person who's pulling the uterus to the side. We used to say to kind of tilt them to the side. It's really hard to do like good compressions when a mom's on her side. So there will be somebody that's pulling the uterus to the side. Once you get to the ED, a lot of times they'll do a postmortem C-section. We say that you have, from the time mom goes into cardiac arrest, we really want baby out within 4 to 5 minutes. So we'll typically start prepping at 4, start cutting at 5. And that may be, I don't know, would you guys do postmortem C-sections, Tammy, on the truck, or would you wait till you got to the ED?
I believe
It's like one of the most controversial ones for us.
Yeah, that would be hard.
Some people are, I mean, if it has to happen, like, hey, doc, like,
Yeah.
I want to do it.
Yeah.
Can I? But
Yeah.
maybe not.
Yeah,
there
because
are some services out there that can.
yeah, interesting.
Ours.
Yeah, so I had talked to the ED, and I'm like, so if they come in, like, who would do that if the doc isn't here, like if an OB is not in house? Because sometimes we just have our midwives in house, so we always have a doc backing up a midwife, but the docs, like if we have a midwife there, there won't be always be an OB there all the time. And I think they said the next best would be general surgery, but I'm like, surely an ED doc could do it too. So yeah, that is kind of controversial, but we've seen good outcomes up to 15 minutes post-cardiac arrest. So just because you've gotten to that 5-minute mark does not mean like we're calling it. It just means that we want to try and get it as soon as possible. This sounds really cold, but our goal for a postmortem C-section is to save mom. So a lot of people think we're taking baby to save baby, but it's really hard to code a mom who is giving everything to the baby. So we are taking the baby to try and make it easier to save mom. Again, that will probably save baby too, because then we can take baby and start working on them over here. But they're not getting oxygen or anything from mom at that point. So if we take them, we can work on them over here, and it is easier to code a mom who is not pregnant, if that makes sense. So
Makes a lot of sense.
yeah. So hopefully that never happens. But there's lots of reasons it could happen. Preeclampsia, if they a stroke, something like that. If they have like an MVA or something like that. Sometimes if they have an abruption or a rupture and they've lost too much blood. They also have AFEs, which is amniotic fluid embolism. So if you have a mom who calls and says she ruptures at home and then she starts coding, that's probably an AFE. We diagnose that by ruling out everything else, really. But that's like an anaphylactic reaction to amniotic fluid getting in mom's bloodstream. And it is totally random. Sometimes it happens. We don't really know why some people have it, some people do not. but the survival rate from that is very low. So I'm trying to
What's your treatment for the epi?
yeah, so we would, well, it's kind of gone back and forth. So we used to say it was A-OK, so atropine, Zofran, ondansetron, and Toradol, Ketorolac. But then they've been saying that just to do it like a normal code and do like the epi. So it's kind of gone back and forth on what we would do, but that would be the doc's call on that. But if they were to code, I would just, for you guys, I would just code them like a normal, yeah, and we could do the rest later. There have been more moms that have survived that here recently, but it's a long road when that happens. So, I feel like I ended on all the bad stuff.
How common is it for a fetus, for a baby to have a stroke while still before born?
I
And
don't
is there
know.
anything that tells that they've had a stroke before?
I think to be able to tell that they've had it before, it would be like testing after delivery. As far as how common it is, I have no idea. I wouldn't say super common, but yeah. Sorry, I don't have a good answer
No, that's
for that.
fine. I know a set of twins that one had a stroke and
Yeah.
the other is fine.
Huh. I was trying to see if I had I forgot to go over baby stuff. Yeah, I don't think it's super common, but I don't know that there's necessarily a way to be able to diagnose that before they deliver. That is way above my scope. I forgot to go over all the things for baby. So after baby delivers, if it's not responsive, a lot of times with adults, you look at the heart, you're trying to fix things with the heart. With a baby, respirations. Usually if you fix their breathing, you fix everything else. We resuscitate a lot of kiddos. Very rarely do we have to do compressions on them. Usually it's because they're not breathing. So drying and stim, getting that baby to go ahead and take that first breath. If you notice that they come out, they're still blue around their lips or their abdomen, they're really struggling. So as far as like, you'll see like retractions, nasal flaring, grunting, things like that, or they're just not breathing at all, they're apneic, you can do the bag mask ventilation on baby. Usually when you fix the heart rate, or when you fix the respirations, you fix the heart rate. If the heart rate is less than 60, so you've been giving good quality breaths, you're seeing chest rise, you're hearing it bilateral, and the heart rate is still less than 60, that's when we would start compressions. You would have one person on usually the compression, so we do it differently on babies, and I know you guys are all trained in this too, but the person would be at the head of the bed, and then the person doing respirations would be at the side. Putting a pulse ox on baby after delivery, if you're like, it doesn't look like it's breathing great, it's still kind of dusky, putting a pulse ox on the right wrist and then watching their SATs. So a kiddo that's just born, their SATs are going to be different than like an adult. So I don't know, do you guys have something like this in the truck that would show you? Maybe if you have like with the emergency delivery stuff, it might not be a bad idea for me to send you that and print it out, because if you look, by the time they're 5 minutes old, we're still only expecting them to be at 80 to 85%. So we're not expecting that kiddo to be at 100% as soon as they're born. They have 10 minutes to still be at 85 to 90. So putting that pulse ox on, watching, if they look like they're struggling but their SATs are okay, like that's a little bit reassuring for that. So just making sure you're clearing all that fluid, everything else.
I think we're taught out in the field, and correct me if I'm wrong, guys, if we look at the patient, if they're starting to improve, pulse ox is good, but it's a tool.
Okay.
So I don't think we pay as much attention
Yeah.
at first, so.
That makes sense. And we have, I think I've had a couple EMTs that have gone through like the basic beginner NRP class, which isn't a terrible idea either. As far as in the hospital, we do advanced NRP, but I feel like the basic NRP would be really great for some people to have, just to kind of know those first few moments what you would be needing to do.
How long is that class?
The basic NRP, I feel like it's usually a couple hours.
Okay, and they get with you
You do it every 2 years. Yes. So I'm not an NRP instructor. We have 5 NRP instructors. They're all our NICU nurses. Well, most are NICU nurses, and then we have 2 RTs. So they teach that. My specialty is labor. My specialty is not NICU and babies. So, yeah, you would want them teaching you that, not me. So respirations for a newborn, 40 to 60, pulse 120 to 160 is normal. 32 weeks or less. So if you don't know what gestation this kiddo is and they come out and they look super small, the biggest thing for them is heating them up. So they don't have a lot of brown fat to keep them warm. It's hard to resuscitate a cold kid. So if you know that they're early, they come out, they're super small, putting them in a Ziploc bag, which sounds really weird, keep their face out. But putting either that or like the bag that the ambu bag comes in or something like that, putting that up from their feet to their neck will keep them warm. Do not dry and stim a very small kiddo or an early kiddo. Keeping that vernix on them, putting them in a bag will help keep that heat, because if they are cold, it's next to impossible to resuscitate them. Sometimes like when we're in the hospital, we have like a heated mattress that we'll put underneath them, and we resuscitate. So if we have a kiddo who's 28 weeks, we're resuscitating that kiddo in the bag. So we kind of go like through the top to put all the things on and stuff because we want to keep them warm. Putting 2 hats on them, warm towels, heat packs, warm fluid bags, anything like that to try and keep that kiddo as warm as possible till you can get to the hospital for us to resuscitate there. Sometimes the kiddos who are super early, you expect them to come out and kind of be crappy, but sometimes they come out and they do okay. You just got to keep them warm. They have like a little honeymoon period where they're doing all right and then they crash. But so they're not always going to come out and be, struggling.
Best access on them is going to be
through the umbilical line. Yeah. Yeah. Typically, if we have an IV placed, it's placed after the resuscitation and once they're in the NICU. And that's kind of, sometimes they'll put it in the arm, sometimes they'll put it in the scalp, but again, that is not something that I do. The little people I'm like, I'll take care of the moms, and then as soon as they're born, I like to ship them off to my NICU friends, because that is not my area of expertise. And then I talked about once you fix breathing, you'll correct most other things. Questions on anything with kiddo?
Will you just, for clarification, I know you went through it in our advanced class
Yeah.
with people, where we clip the cord, where we do the cord and cut it and not too short.
Oh, yeah. Yeah. So that's what, with this, say this is your placenta. I would say, well, pretend this is not on the placenta. Pretend this is on baby. I would say, I don't know, maybe here and here. You want to give enough room in between that you can cut the cord. And they're not super easy to cut through. If you've ever cut through one, they're kind of juicy. They're a little chewy there. All very terrible adjectives that I'm using for. And then once you clip on this side, like if this is still in mom, just leave the cord on because we'll use that to kind of do traction once we get to the hospital. Another thing I didn't go over is hemorrhage. So if the mom delivers, do you guys, I know the ED is carrying IM pit. Do you guys carry Pitocin on the truck? Perfect. The best and most amazing thing you guys could do is if that mom delivers, give her IM pit just straight away would be chef's kiss, because that is going to help her uterus clamp down and prevent that bleeding. So in the hospital, when a mom delivers, as soon as we clamp the cord, that's when we bolus our Pitocin. So anytime after you clamp the cord, if you could give IM pit, that's just delightful, because we give it prophylactically to prevent any kind of hemorrhage. If you think about with mom, once this placenta detaches, they have a wound this size, give or take, inside their uterus that is just bleeding. So all the blood vessels that are going to this are just wide open. So if her uterus does not clamp down, she's just going to continue to bleed, and that's when we see the hemorrhages. After they deliver, you can do fundal massage. So don't overthink it. It's just right about the umbilicus. You're just doing you can't do too hard, but just rubbing their belly, and you'll feel her uterus clamp down. If you feel her uterus in a hard ball right there, that's wonderful. It means everything's clamping off. That's our main cause of hemorrhage is tone. So if the uterus is boggy or isn't clamping back down, that's our main source of hemorrhage typically. So giving Pitocin, doing like a quick fundal massage, just making sure everything is firm is delightful. Another cause of hemorrhage would be like, so we say the 4 T's. So tone, trauma. So if she has a bad tear that she's bleeding from, that would have to be repaired by the physician. Tone, trauma, tissue. So if there's pieces of the placenta still stuck in there, the physician will do a manual sweep to get all of that out. So it's just what it sounds like. They stick their hand up there and pull it all out. So, yeah.
That sounds awful.
That's rough. See the little lobes of my placenta. Yeah. So there's little things back in there, and that's what they'll do. And it's really awful when it's someone that didn't have an epidural, because that just really sucks. But that's what they'll do. They'll go in there and take their hand and sweep the uterus out to get all of it out. If they can't get all of it out that way, then they will go for a DNC, and that's when they'll actually go to the OR and get all of that out. Yeah, it makes you feel really bad when it's rough. The other T is thrombin, so if they have a bleeding disorder and they're not clotting well. But yeah, Pitocin is great. I forgot to go over hemorrhage. I'm surprised I forgot to go over hemorrhage, because that's like one of the main things that...
Well, I was trying to think of some of the things you went over before.
Yeah, so I think I went preterm birth breach. Yeah, I'm surprised I didn't put hemorrhage on here. That's strange. Okay. I mean, that's one of the most common complications that we see, and you guys would see. If it's a mom that is her 7th kid, you'll have to be less worried about dystocia and more worried about hemorrhage, because her uterus is so tired. She is also probably so tired.
She's also what?
So tired. But yeah, if it's a big kiddo, multiple deliveries, if it's one of her late, like she has a bunch of kids, those are all really good risk factors for hemorrhage, because her uterus is just not going to clamp down like it used to. So, questions on any of that? Okay. I think that's all I have. If you guys don't have any questions on anything OB related.
Any questions?
Okay.
Fire guys, you're gonna be ready for this, so when we come rolling up, you'll have the baby delivered and mama take care of it.
That'd be ideal. Just if you could go ahead, deliver, dry and stem, latch her on, that'd be great.
Latch her on.
Yeah, it'd be great. You can bring her up to us once she's through 4th stage.
That's the least of my worries.
I know. Yeah, it's been a couple weeks ago, we had somebody that was coming in that delivered in the car, and they're like, they had called 911, but then she's like, we're not stopping on the side of the road. So I think that, I think it was just the police officers, that just brought her in, and
Really?
yeah.
Wow.
And most of you guys know that have brought patients to us, the ER and the birthing center are so far apart. I don't know who designed that.
Figure out why they put.
I know. Well, Stacy Glick.
It seems like there ought to be there's an entrance to the ER when a transition from ambulance to, there ought to be something like that for birthing center as well.
Yeah.
Mm-hmm.
So it's not like out in the street,
Yeah.
at the front door.
Yeah. We usually say, like, if we think someone's coming in and is going to deliver quick and the ED calls, like you guys call the ED calls us, we'll say bring them to entrance 4 because it's just closer. But yeah, we've had patients deliver in the hallway on the way up there.
Guys, I am going to apologize in advance if I yawn a few times. We got in last night at midnight from vacation. So here we are this morning. I think everybody here knows me, but if not, Jen Brown. I worked at Columbus Regional Ambulance Service for about 15 years and then hung up boots when I was 8 months pregnant with our second kiddo. Haven't gone back, but have my cert still just in case I ever decide to. And I've worked at Riley. Well, I started at Methodist in the Riley Pediatric Critical Care Unit at Methodist in 2007 and have been in the ER at Riley since 2013. So I'm one of the I'm the clinical specialty coordinator now, which basically means I get paid to do more work that I didn't want to do in the first place. But I also do all of our training. We're going to go through kids today and very casual. If you guys have a question, if you have a comment, if you have anything, let me know. We're going to go through trauma. We're going to go through burn. We're going to go through some child abuse and neglect, some child-friendly tips, things that you guys can do to make your runs a little bit easier. I know that all of our IEMS friends up north always talk about how we're the last people they want to have to come see. They don't love their kid runs. Nobody really does, but I would much rather run on a kid than an adult. So it just is all down to your preferences. Good morning, Grayson. So we'll get started here. Tammy, does the clicker work for this or no? Well, maybe not.
It wasn't working a while ago.
Okay, that's okay. We can tuck and roll. All right. So first off, what's a trauma center? What makes Riley or Methodist or Eskenazi different? A trauma center, they are committed to the advanced care of patients with severe multiple injuries, and then we are nationally recognized by a benchmarking authority. We have a trauma redesignation or reaccreditation about every 2 to 3 years, and we just reaccredited this year. The responsibilities that we have as a trauma center, we have a trauma team that we notify and that will respond anytime you guys bring us a trauma. So if you bring a trauma directly or if you fly someone, there's a team that will be assembled based on the severity of injuries, and we'll get into that. We have to have 24-hour, 7-day-a-week availability of specialists, certain equipment, supplies, and ancillary support systems. We will definitively stabilize patients, whether that is pediatric or adult. We had an adult who was working on construction at Riley the other day who got hit in the chest with a crane and had a nice soup bowl of a chest when he got brought into the ER directly from outside of the building. So we stabilized him and then transferred him to Methodist. We also have a rehab unit, and we'll promote that. So we do their long-term care from time of injury to the time they're able to return home. We do education, obviously, and best practices, our doctors, and then we also have PCOM, which is our Pediatric Outreach Medical Unit that will come out and do education with you guys as well. And then if there are specific topics that you guys ever want to have education on, feel free to reach out. One of the docs in the past has come with me to do a pediatric airway lecture. He was on today, so he couldn't come. I have a pharmacist who can come and go through drugs and meds and things like that with you guys. So if you have things you want, let us know. We also do injury prevention initiatives. So we do like bike helmets, car seats. We do fire safety month. When you guys are having fire safety month, we also are passing out smoke detectors, doing fire education with families, burn education. And then we also are heavy into research. So our verification criteria that we have to have an OR that is up and available to take a patient within 15 minutes. That means surgeon in the room, scrubbed in, anesthesiologist, nurses, scrub techs, and available equipment. Our IR has to be available within 30 minutes for any vascular injuries that we need. MRI has to be available within 1 hour. It's usually less than that, especially if it's one of our trauma patients. Our consults have to be there within 30 minutes for our ortho folks and our neuro folks, but again, they're usually there quicker than that. For a trauma 1, and we'll go through what criteria separates a trauma 1 and a trauma alert for you guys, our pediatric surgeon has to be there within 15 minutes, but I'll tell you, they'll be waiting in the room for you when you get there. We have pediatric surgeon admitted trauma alerts. So anytime someone comes in that's a trauma alert and they get admitted, the doctor just has to see them within the first 6 hours. Our ER physicians will stabilize and rule out kind of the big, bad, and ugly. And then if they need to escalate to a trauma surgeon more quickly, they will, but usually it's within 6 hours. They have to see them before they get discharged. We get a fairly good number of trauma alerts that come in that we're able to just kind of get sedated and splinted or casted, or do like a plastics sedation to get things stitched back up, OBS, and then sent home. So they don't always get admitted. Transfer outs, like I said, they have to see them within 2 hours. We have our golden hour patients. So those are the patients that we have antibiotics within 60 minutes. So those are not only our traumas with open long bone fractures, they're also like our fever neutropenia kiddos. So our hemonkers, our sickle cell kids with fevers, our immunocompromised kiddos, our asthma kiddos, all our golden hour patients, they all get steroids within the first hour of arrival. But those are things that we've, through research, realized is going to make for a better outcome for the patient. And then we do screening and brief interventions for every patient 12 and over, and this is called a craft screening. We ask questions to every kiddo, and this is like an early intervention or an early catch for drug and alcohol abuse problems. And we do that so that if they flag, we can have someone kind of go through that with them and go through resources with them, but also with their parents. We have Narcan kits that we give. Unfortunately, we have kids as young as 12 who we see on the repeat who are there for overdoses, who already have a problem. So we do have those, or we also have parents who unfortunately their kiddos got into mom or dad's whatever, and oftentimes we will send those parents out with Narcan as well, because unfortunately we can't fix the parent's problem, but we can prevent the kiddo from having a negative sequela. So we have all of those things as well. These are our trauma ones, and these are kind of what we go through. The normal vital sign range is up at the top, so there is a section where if it has compromise to any of those vital signs. I also brought badge buddies for you guys that have pediatric GCS on one side and pediatric vital signs on the other, so if anybody wants one of those, you're welcome to have one. So cardiovascular compromise, these are our kiddos that are outside of any of those limits. Now, if they're screaming because you're scary, that's not necessarily a trauma 1. This is in light of a trauma mechanism. Systolic blood pressure less than 90 unless it's age-specific range related. Patients that get blood, crushed to glove, pulseless, or mangled extremities. We have what we call the black box criteria, and so anything that is in here all the way down to the knees and proximal to the elbows is all considered trauma 1 for penetrating injuries or anything else. If we have a gunshot wound that is from the elbow down on this or the knee down, that is just considered what we call a green swarm, which is an ortho-related injury. The only time that changed would be if you guys have like a vascular involvement that you're concerned for, like arterial bleeding or a compromise for the pulse in that extremity, okay? Pelvic fractures with hemodynamic instability. A lot of times we'll get kids that have pelvic fractures, but hemodynamically they're pretty stable. That would not necessarily be a trauma 1. It could just be a trauma alert. And any extremity paralysis suggested of a spinal cord injury, so numbness, tingling, weakness, anything along those lines. Kiddos who are found down, so anybody who is less than 5 years of age and they are found down that do not have like an extensive medical history, not a trach kiddo, something like that, or anyone who doesn't have a physiologic trauma reason to be found down. The reason is because unfortunately child abuse is the #1 reason that we have kiddos brought in that are found down, and it usually is not a good outcome when they're less than GCS of 13 when they're brought in. Known button battery ingestions. Does everybody know the button battery thing and why that's a thing? If you're looking for something to do on a rainy day, get a hot dog and put a button battery in it, walk away for 30 minutes and come back, and the entire area around the button battery will be black. The reason is because it's a thin-walled battery and it will eat, the acid seeps out and eats into anything. I've had a couple of kiddos who unfortunately were not able to save. The button battery had been in there a long time. It had eroded, and by a long time I mean like 12 hours, it had eroded through their esophagus into their aorta, and their aorta ruptured in the ER. We can't fix that. So it's very important if it's, we think it's a button battery, or that the parents say, I don't know what it is, to get them to closest definitive care and get an x-ray so they can decide if it's like a quarter, a coin, a button battery, Polly Pocket, a Lego, whatever. Respiratory compromise or assistance, GCS of less than or equal to 13. Kids are hard for GCS, so that's why I have badge buddies for you guys, so you guys can use those as a guide. Patients who have gotten 2 or more fluid boluses. What is the initial fluid bolus for a pediatric patient? Do you guys know? And it is okay if you don't. It's 20 mils per kilogram. okay? You can repeat that up to 3 times. If you get to your second 20 per kilo bolus and it's still not helping your blood pressure, at that point we need to look, do we need to have a pressor or blood product, okay? Amputation that's proximal, so above wrist or ankle, burns that are greater than 15% or high voltage, so that would be not just a light socket, that would be like a transformer or something that's a little bit more voltage. Open skull fractures, and then any penetrating trauma to the head, neck, chest, abdomen, extremities, and that can be a gunshot wound, that can be the kid running with a toothbrush that went through the roof of their mouth, that can be the blow dart that went up the kid's nostril and lodged in the base of their brain, all kinds of things. You would not believe some of the stuff we see. And then sometimes we will activate it based on our discretion. Trauma alerts, these are our motorcycle or moped crashes greater than 20 miles an hour. High energy dissipation, so this would be like our Amish friends who are horse and buggy accidents. These are our golf cart kiddos ejected from an ATV. Kiddo that's riding down a hill on a bike and flies over the handlebars and hits a wall or a car. Blast or explosion injuries, the teenage boy that's lighting his farts with a lighter and it doesn't go well, all those things. Falls that are greater than or equal to 20 feet or 3 times the height of the child. So stairs are kind of the things that throw people off sometimes. Stairs are not considered a trauma unless they have a medical compromise associated with the fall. Stairs are a series of small falls, and even if they've fallen down 45 feet worth of stairs, it's still not considered a trauma to us unless they're altered, they had a loss of consciousness, pupils aren't equal, they're vomiting, walking funny, not acting themselves, something along those lines. The reason is because when you fall, you guys all know this, the mechanism of injury is the rapid acceleration and then the sudden deceleration. It's that immediate stop, and it's usually from a higher level. The little falls are more just little repeated falls. Peds that are struck by a motor vehicle, and then high-risk motor vehicle crashes. So over 40 miles an hour, anybody in the same vehicle dies. Moderate intrusion, so that's usually 12 inches or more, or ejection or partial ejection. Additionally with that, if they are unrestrained and should have been restrained, or if they're restrained and the restraint was not restrained to the car, these are all things we see fairly frequently. Those kiddos will be a trauma alert just to rule out that there's nothing else going on, okay?
Quick question.
Yeah.
What's the age limit to take pediatrics to Riley?
You can do 16 and under is typically. The reason we can do 17 and 18 if they're smaller stature. The issue is that some of the 17 and 18-year-old boys are big boys. Those typically do better at Methodist and Esky, not because we don't know how to care for them, but because of equipment. So if they would need like IR or things like that, some of our sheaths aren't big enough to get to the injury. So that's why we typically will go with adult for those, okay? But if you accidentally bring them to Riley, guess what? We're not gonna tell you to go away. We're gonna take care of them, and then we'll go from there and see. Because we do get 17 and 18-year-old traumas from time to time that we keep. And then major joint dislocations. So if you have like a shoulder, a knee, things like that that have dislocated, especially if it doesn't have a distal pulse, okay? So why do we ask you to call so we can pre-activate a trauma? So we ask you guys to call for any time you're bringing us a trauma, and honestly, even if you're just transferring a patient from another hospital, if you guys can give us a 20-minute call, that is super helpful to us, but also it'll be helpful to you guys because we will get you back on the road faster. If you're looking for a break, don't call ahead because then you can stand in the hallway and visit with us for a little bit. But we're usually pretty full by about 10 a.m. And if you call ahead, we can get a room cleared out. But for a trauma, we get all of our resources, we page it out, we make sure that we have blood bank on standby, get an OR ready, have the ICU bed available, radiology, all of those things, and then make sure that the right people are present at the right time. When you guys come in, just so you know, if you bring in a trauma, you are being videoed. It is not to make sure you're not doing something wrong. This is part of our research, but it's also our learning. We review every single trauma that comes to Riley and look at timing. Did they get blood products appropriately? Was there an issue with equipment? Was there a safety concern? Things like that. Every single trauma one gets reviewed and every medical alert, so a code. So just know that you're in there. And also when you get into this room, you'll come through the curtain. There will be lots of people in this room. You guys should be getting a 60-second salute. Like everyone in the room should be shutting up and you have the stage. That is 60 seconds of your time. And if you are not getting that appropriately, you need to talk to one of us because that's not the expectation. We can only do so much until you guys kind of give us a handoff of what you saw. And it's super important to hear all the details, okay? So blunt trauma, just to review, it's a combination of forces that don't penetrate. There's often more life-threatening than penetrating injuries. They're less obvious, and in kids, their bellies can expand pretty big before we really realize there's a whole lot going on in there. And they also compensate until they don't compensate. So motorized vehicle accidents, pedestrian struck, falls, assaults, bicycle accidents, handlebar injuries are kind of a big red flag for us. And then also if they were appropriately restrained, they should have the force on the parts of the body support them. But when they're inappropriately restrained with like a lap belt or something like that, there may be intestinal mesenteric injuries, things like that in there that you can't see until we start looking at it with some CT or radiology. So again, we need to know the approximate speed, the number and size of vehicles involved, the point of impact. Did it hit right outside the passenger door of that patient? Was it on the opposite side of the car? Were they thrown, drugged, pinned, run over? Any of those things we need to know. What the restraints were, what the safety devices. Like I said, we've had lots of cases where the kiddo was in like a pumpkin seat, like an appropriate child restraint. Everything looked great, but the dad or the mom forgot to buckle it into the car. At that point, it really doesn't do what it's supposed to be doing. If they're under 13 years old and riding in the front seat, or if they're over 13 and they're very small stature and riding in the front seat, has a different constellation of injuries that we're looking at. Ejected, rolled over, deaths of other passengers, prolonged extrication time, and then the amount of intrusion or damage. So acceleration, deceleration type injuries or shearing injuries is what we're looking at there. A lot of spinal injuries will happen from this. Liver lacerations. This is a lap belt injury diagram, and it just kind of shows you where when they move forward, it's hitting that liver, that costal region of their liver, and can cause some pretty significant bleeding in there. It's tearing at their mesenteric area of their intestines, so we don't want that either. And then if there's multiple impacts, so like the vehicle is going to hit something, right? And then the patient's going to hit the seat belt, and then the patient's going to hit the car again, correct? Because it's bouncing back and forth. So lots of things. Head-on collisions we're looking for, was there starring on the windshield, steering wheel, or dashboard deformities, impact with another seat, person, or object. I don't know about you guys, but I am guilty of having a car full of stuff sometimes that if you have a rollover accident, it's flying everywhere in the car. So even if the person is appropriately restrained, they may have gotten hit by something in the vehicle. And injuries to their neck, chest, or abdomen. If the seatbelt hits right here on their neck, we're also worried about like a IVC or an internal carotid injury or dissection. Those can be hidden pretty quick. For a pretty good amount of time. Same side of their shoulder or clavicle injury, same side as the T-bone accident. We talked about head and necks. And then any ejection related injury, and that's to, head, neck, shoulders, but also limbs sometimes. And then if they're pinned from more than, we say 50% of their body under something, you have to watch for them to have flash hypovolemic shock, right? Because it's compressing down here, and as soon as you get that off, all of their blood flow is going to drop, and you'll have a really rapid drop in blood pressure, a lot of times cardiac arrest. So things to know. What type of seat they were in, if it was rear facing or forward facing, if it was a 5-point harness or a booster seat, lap and shoulder belt, were they in it? We've also had that before where there were car seats in the car, but the kids weren't in the car seats. Is the car an older car? Is it a newer car? Are there lap and shoulder belts available? Are there airbags available? All of those things are important things to know. If we have a kiddo who is struck by a car, it is superbly helpful to us if you can tell us what type of car. Low car, high car, SUV, truck, bus, whatever it is, just because then we kind of know where to concentrate our efforts in terms of immediate assessment, okay? A toddler who gets hit by a Mazda Miata is gonna have a whole different constellation of injuries than a kid that gets hit by like a Suburban, right? A lot of times the Miata, they will get hit and they'll go up and over with a SUV or something like that. They'll get hit and then drug under. So there's a lot of different ways that they can have injuries. So that's super duper helpful. If they were thrown, and then where they were after the impact, and kind of were they hit head on, were they like this when they were hit, kind of how did that work? Distance of fall, point of impact for the body, type of surface they landed on. We have a lot of parents who bring in their kids that are like, they rolled off the bed or they rolled off the couch. Normal. Not normal when they're 3 days old, right? So looking at that as well, does the story match what they're telling you? If I get a 2-week-old that the parents are like, well, I left them on the bed for 2 minutes and they rolled off, I have a high index of suspicion for child abuse at that point or something else going on. We have had some kids who like siblings jumped on them or landed on them. That can cause some pretty significant injuries internally. So just knowing kind of what the story was behind it. If they get assaulted, did they use like a closed fist? Did they use a baseball bat, a brick? Were they using, you know, pointed objects? What are those things? Where were they hit? How many assailants? We have some kids that get jumped at school or jumped in the park. And it kind of depends on, you know, like how long were they attacked, or were they attacked by multiple people, or did one person beat them up and then another person came in to help finish the job? Just depends. So knowing that is helpful too. Bicycle accidents, were they wearing a helmet? If they are in a dirt bike as well, like do they have the protective gear? We get some kiddos that are in town for like professional dirt biking events, and some of those kids are little and going real fast. So knowing kind of what protective gear they have on and all of those things. What did they impact? So another vehicle, a pole, a handlebar. If you have a kiddo that hits the handlebars, have a very high index of suspicion that there could be an injury here or here. Just depends on where the bruising is, and kind of know that. How far were they thrown, when they landed, how were they found, all of those things. Loss of consciousness or not a loss of consciousness. Honestly, abdominal injuries can be just as bad as head injuries sometimes if we don't catch it quickly. So all the things to know. Penetrating trauma. This is when an object passes through tissues. This can be a bullet. This can be just pretty much anything. A kiddo that was in a car accident with a semi, and the pole they use for when they, what am I trying to say? Like to jack up the semi. You know what I mean? Where it raises it. Yes. Crank. Yes. They were impaled by the crank through the car seat. So you never know what you might get. They don't follow straight paths, especially if it's a low caliber. It will go in and bounce around, causing a whole constellation of injuries you can't see from the outside. If there's no exit wound, a lot of times we're a little bit more concerned about that because we don't know where it landed and went beforehand. High velocity weapons can also cause concussive injuries. So when they go in, they don't just go straight through, they kind of cause a tunneling effect. And so they're affecting a lot of the tissues around. They'll also, even if they go straight through, they're gonna cause bruising to all the tissues. The one positive is sometimes they self-cauterize. So as they go through, if they hit a vessel or something, that bullet is hot and it will cauterize. So sometimes you get it through and through. And honestly, we don't really do much besides wash it out, give them a dose of antibiotics, and send them on their way if there's no compromise. So it just depends. But again, we need to see it. I talked about this. Bic pen, that was one. Running with a Bic pen, and it went right next to the sternum in that little hollow space between the ribs and the sternum. That kiddo was okay, but looked intimidating. The knife, the dart to the knee. We had a little girl who was riding a scooter, and the back wheel on one side fell off, and she fell on it, and it penetrated through her buttocks. The wheel came off, and then there was the rest of the axle or whatever sticking out, and so EMS transported her in with her scooter still hanging off her, and we got that out. That one did have an issue because it was actually through her rectum and had caused some colon injuries. So you just don't ever know. And then we do, we'll look at it. We need to know a tetanus status. So especially if the parent's not coming with you, if you guys can just ask, are their immunizations up to date, or are they not immunized or whatever? If we don't know, we'll give them another tetanus regardless. Give them the antibiotics within an hour, and then we usually do either a sedated washout and exploration in the ER, or we'll take them to the OR depending. I was talking about the black box. So this is kind of, we've already covered this, but those are the things that we are looking at. With explosions, another thing to think about is if they were in a house fire or something exploded in the house fire, they can have ruptured TMs. They can also have issues with brain injury from that, but also inhalation injuries when you have a blast explosion. Be careful and make sure that that's not a problem as well. We talked about most of this. Secure it if it's not something that just falls out on its own, so that it doesn't cause more damage when you pull it out. Sometimes what's in there is basically holding that vessel shut, and as soon as you remove it, you have a whole nother issue on your hand. If they have expanding hematomas, so like you see an impalement here, but then you see like a blossoming bruising or hematoma forming, probably we have some pretty extensive vascular involvement, so we want to get them transported quickly. Or if it's pulsating, if they, we had a kid that went through a plate glass door one time and had a huge laceration over here on the side, which wasn't a huge issue. What was a huge issue was that every time he took a breath, it bubbled. So he had an open chest cavity. So that's a problem. So things like that, just look for those little signs. I think those are the big things. If it's something that we think might need evidence collection, if you guys can try to not like wash the hands or different things like that, if you can try and do your IVs up here further, if you can preserve any clothing. So we always say to get them exposed so we can kind of see what's going on, but if you can save the clothing and things like that, police oftentimes will take those for a chain of evidence just to see if the story matches kind of what they're doing. And then if you have sterile sheets, if it's something that you are concerned was like a crime, if you can put them on a sterile sheet and then expose, then we can wrap the sterile sheet around them and the clothing will be, you know, contained in that as well. But we can worry about that later. The most important thing is getting the kiddo handled. Any questions over that portion with trauma? Kind of racing through it, but I think most of you are pretty well versed in this. We're going to go through burns. Burns injuries, so we said accidental injuries are the leading cause of childhood deaths in the U.S., and that is accidental and non-accidental. Burns are the third most common injury causing death. What do you think is something we see very regularly?
Boiling water.
Yes. So mom was drinking coffee and it accidentally fell on the kid while she was just, you know, sitting with the baby. They were making something in the microwave and the kid reached in and pulled it out and dumped it on themselves. Ramen noodles are the devil. The water burns them and then the noodles stick to them and cause a secondary burn. So anything like that, hot soups. The other thing that we see fairly commonly is we have a high population of like Haitian Creole and Burmese, and they fry things a lot in like the woks, and so they'll have oil heating and the kid will pull the oil and it splatters them. So all of those things. And then bonfires during trauma season, which is now. We'll see campfires and things like that where kids were outside and fell in a campfire or something in the campfire exploded. Scalds, like I said, those are 2/3 of all of our burns. They're the most common thermal injuries in kids under 3. And sometimes it's not even something the parents meant to do. Sometimes it's as simple as a bath or something like that. Kids' skin is much thinner than an adult's, so even when you put your hand in the water and it doesn't feel hot, sometimes it can burn that child without you even realizing it was that warm. And we'll go through like temperatures and things here in a minute. Flame burns are more common in older kiddos. It's a common form of child abuse, especially during potty training stage. Parents will be frustrated when they have an accident or something like that. And we see a lot of where they've bathed them or stuck them down in a bathtub or something to rinse them off, and they didn't care that the water was hot, or they wanted the water to be hot, and it will burn them. We call those dip injuries. And then house fires. They're the leading cause of injury death for African American children 1 to 9 years of age. A lot of times these families are living in rundown houses with poor electrical wiring. They don't have smoke detectors. They use the stove or space heaters to heat their homes, things like that. So it sort of sets them up for failure. So the exposure of skin from 111 to 120 degrees Fahrenheit is well tolerated. However, for kiddos, if it's over 130 degrees Fahrenheit, this is why you want to keep your water heaters set at 140 or 130 or less, I'm sorry. Exposure for 30 seconds for an adult could cause a burn, but it only takes 10 seconds for a kid, which if you think about it, that's not very long, right? 140 degree water heaters, less than 5 seconds, and 160 is a full thickness burn that will occur almost instantaneously. So if you think about it, we want it 120 or less on your home water heater. I like taking a hot shower, so ours is set at 120, but I would be okay with it a little warmer. But when you have kids, set it lower. Extent of burn injuries, if they're larger burns, it's typically a worse prognosis. So we've had kids who accidentally set themselves on fire with gasoline trying to make a bonfire, things like that. Anytime it's a larger burn, it's definitely a worse prognosis. I'm sure you guys all heard about the police chase in Avon where the car hit a car and the 2-year-old, he was about 98% burnt when we got him, and then the sibling was also burnt in that. The 2-year-old, we did end up doing what we call a declaration of cardiac death, or letting him go because there was no prognosis for him to heal from that. His name was Aries. The sibling was okay, but the car burst into flames when the guy hit it, and the dad and the police tried to pull the kid out, but they could only get the sibling out, and then the seatbelt or the car seatbelt was jammed in the car seat for the other kiddo, and it took longer. So we'll have things like that. Using their base of their palm to their fingertips is what we consider 1% total body area. So you can kind of use your 9s on that to calculate that. If infants have greater than a 10% burn, we want to start fluid resuscitation, okay? And if it's a kiddo, we usually say school-age kiddo. If it's greater than 15%, you want to go ahead and start fluid resuscitation. Lactated ringers is the preferential fluid, but any fluid, if you guys have just normal saline or whatever, any fluid is better than no fluid. Anytime they get dry or premorbid dehydration is what they refer to that as, we are usually going to admit them for fluid resuscitation if nothing else. So there's different things you can do. There's a Lund-Browder chart, there's a rule of 9s. Their palm is considered 1% if it's scattered. When you are measuring a burn, if they have a burn that covers here to here, what we're looking at is not just first degree or partial thickness or just surfacey. We're looking for partial thickness burns, okay? And we'll go through it. It's partial to full thickness or counted. So usually if they're burnt by water or something like that, they'll have the little splash marks, right, on different areas where it's just like a sunburn. It might be red. We're looking for blistering or deeper tissue involvement when we consider what our burns are. So we do get quite a bit of kids who EMS will call and say they're like 20%, and then it ends up they're only like 9 or 10 because of the areas that they calculated. And these are the different things that go through. You can remember this. I always just use their palm. Okay, that's the best way you can do it. Even our burn docs do it that way, okay? First aid at the scene. So the first and most important thing, obviously, you guys know this, is to protect yourself and make sure it's safe. So is the house still on fire? Are there chemicals in the air? Are there substances on the child that could affect you as well? So like keep yourself safe. If you're not safe and you get injured, you can't take care of the kiddo, right? So assess to ensure that they have cardiorespiratory stability. And then also, if it's a house fire, like did they fall through the floor and maybe they have a musculoskeletal injury on top of a burn on top of something else. 100% oxygen if applicable, if they're having any respiratory involvement. Large bore IV access, folks, I'll take a 24 if you've got it. We can push whatever we need through that if need be, okay? But access is access. IOs are fine as well. Remove smoldering or contaminated clothing unless it's pulling a large amount of tissue with it. If it is burnt into them, leave it in place and just cover it with a dry dressing or a sterile burn sheet. Chemical burns, irrigate those with whatever they should be irrigated with. Obviously, you guys want to check your MSDS to make sure that it's not something that's activated more by water. Some things you can't clean with soap and water, so just making sure that you're doing that appropriately. Covering with a clean, dry sheet. No topical medications will get kids in and they have like mustard on them, toothpaste on them, butter. Trying to think, like there's all kinds of random things, and then they'll get the over-the-counter burn cream and slather them in that. And honestly, we will take all of that off. So just clean and dry. Any burned extremity, if they leave it dependent, it's going to cause more swelling. So if you can elevate it and then just check pulses frequently to make sure it's not causing like a compartment syndrome or something when you're elevating. No ice or cold water. That is causing vasoconstriction, which is what we're already concerned about with the burn. So if you put ice packs or cold water on the burns, it's literally taking the little bit of perfusion that they're getting to that tissue, which will help kind of slow the burn down, and it's just making it worse. So just clean and dry. That's the best thing you can do. And then evacuate without delay to a medical facility. If you guys have a significant burn, having them flown to Riley is ideal because we're the only pediatric burn center in the state. And I am not a burn nurse, do not want to be a burn nurse, but God bless our burn nurses. They do magical things for these kiddos, and the quicker they can get them, the better, okay? And then if anybody's ever interested, they have classes, I think they're going on right now, and I can send those dates to Tammy, at Eskenazi as well, that are free. And it's a trauma burn class where you learn about like how to care for burns and things like that too. So if that's something that you're into, not myself, but if it's something you're into, they have those. So immediate resuscitation, you're gonna prepare for transport. If they're having severe respiratory distress, if they have a large total body surface area burn, if they have airway involvement, if it is anything, intubation early is super, super important because their airways are already small, and I can tell you that they will get even smaller as the minutes tick by. We do a lot of kind of proactive intubation with anybody that has like facial injuries or that has any stridor. I'm not necessarily concerned with soot on their mouth, but if I can hear them stridorous or I can see it in their mouth, then I'm a little bit more concerned. And those are usually the kids we end up tubing. And then if you tube them, just be aware with skin sloughing and things that they can lose their tube position pretty quickly and easily. So just assess and reassess their tube. And then what can you put on your tube to also help monitor how well your ventilation is going? Yeah, Capno. Capno is clutch. That's the golden standard at Riley. We have that for anybody. And we even use Capno on our kiddos. They're getting a nasal cannula if we're having any respiratory concerns. So CO, intoxication, it's most frequent. It's an immediate cause of death. You guys probably all heard about, there was a recent guy was working in a basement with a gas-powered tool of some sort, and the firefighters went in to get him, and they actually all ended up getting sick as well because there was so much CO in the space and they didn't realize that's what it was. So just taking care of yourself as well and making sure that we're airing it out. It has a higher binding rate to hemoglobin than oxygen, so you may get that kid out and put them on a pulse ox and be like, well, they're fine, 100% FiO2 or SpO2. Well, it's not, because their oxygen binding have all been filled with CO instead of oxygen, so they're actually not okay. I think everybody, CFD has the monitors in the truck, right? The pulse oxes that have the CO detectors on them. So check those anytime you guys have concerns about that. And then we will give them a cyano kit. So what it does is it goes in, it's a form of vitamin B12, and it will bind with the cyanide, which is the byproduct, and it pulls it out of their bloodstream faster. And then it gets flushed out. Their urine turns neon pink. It's actually kind of fun color. Not for them, but they also will get hypertension and their skin gets super flushed. But if you're gonna have to have pee, pink is fun. So we'll have those things, and we give those in house fires a lot. We talked about this. Know the weight of the kilo for the patient. Braslo tape, whatever you need to do. If the parents know, last time we went to the doctor, they were about 40 pounds, however you can estimate that best, knowing that. If they are 20% total body surface area or greater burn, we would fluid resuscitate these. We're preventing hypovolemic shock and maintaining our end organ perfusion. Hypovolemic shock is the #1 cause of shock and decompensation in kiddos because they have a lower circulating blood volume, but they also have a higher water content in their body. So they can get dehydrated a lot faster. Again, large bore or a 24, I don't really care. You're gonna start it at 3 to 4 mils per kg times the total body surface area that was burnt. So for example, if you have a 23 kilo male patient and has a 45% total body surface area, it would be 23 kilos times 45 times 4 mLs. So you're going to give 4140 is what we're going to give him. That seems like a lot, right? But over the first 24 hours, you want to give the first half in 8 hours, and then we slow it down to a rate over the next 16 hours, okay? So we want to give them that bolus, but then we're going to slow it down so that we don't end up having a pulmonary compromise as well. If you can't remember it, these are also great fluid rates to just use and not have to try and do all the math in the back of the ambulance and figure out you don't have pumps. So just trying to use drip rates and do it this way. If you think about it this way, your transport time, depending on if you're going to Riley or not, is about an hour, so you can eyeball and make sure you're getting about that amount of fluid in. Reassessment and assessment of lung sounds is very important just to make sure they're not getting flooded from some of that. And like I said, LR is our fluid of choice. However, whatever you can use is perfect. So there's our thermal burns, which are scald flames, and then contact. So the kid that rolled over in his sleep and got wedged between the dresser and space heater and had significant burns here because he couldn't get unwedged quickly, and so had burns here. Chemical burns from cleaning materials, different things like that. We have kids that drink bleach trying to kill themselves. I could think of a lot of ways I would do it that would not involve having to drink bleach, but they will do it and they'll have burns from that. And then electrical burns. So first degree, it's your epidermis. It's like a sunburn. It's painful. There's nerve exposure. The most effective thing you can do to relieve some of the pain in a burn is to cover it. A big part of the pain in a burn is those exposed nerve endings, and when you cover it, then the air movement over the top of it isn't actively causing those to flare. Okay, fentanyl is also great. Second degree or partial thickness burns. These are mid-partial, deep partial, and superficial. And those go down more into your dermal layer, so your epidermis and your dermis, and then into your hypodermis. Third degree is going to be your full thickness, and those are going to go all the way into your musculature and sometimes in bone. And again, we want to look at the amount of dermis that's remaining because we can do skin grafts and things, but the stretch, the collagen and things that allow for movement, especially over joints, once that's destroyed, we can't replace that. So that's why a lot of times those kiddos will come back in because they'll get really contractured and they'll have to have release surgeries in the future and things like that. So this is superficial or partial thickness. So this is a pretty good example of a dip burn, where they've dipped the kiddo's foot into the water in and out. If you think about it, if they stepped into the bathtub, they're gonna try and jerk their foot out, right? And there's gonna be splashes and things. So this is a pretty good one. And different things that they've grabbed or put their hand on, or a campfire, different things. They're gonna blanch when you push on them. They're gonna be pink or blistered. They're painful. They will heal on their own with proper treatment. We don't have to do a whole lot. When they come in, we will I'll cut all the way around the blister, and then use a couple swipes with some gauze and baby soap and water to get any of the other tissue off. And then I will cover it with a dressing that has Silvadine in it. And then wrap it, and they'll follow up in burn clinic in 7 days. So pretty basic. It's not a huge injury. They heal really well. Mid-partial thickness. So these are when you have more dermal involvement. There's going to be areas of eschar, which is when your protein in your skin is affected as well. They'll have delayed blanching. They might be pale or pink, pale pink. They're very painful because it's now down into that root bed, nerve bed. They can heal on their own, but we do usually admit these kiddos. They have to have proper bandage changes and different things like that. So these are a little more significant. Deep partial thickness. So these are the kiddos, like this is one where they've pulled hot oil down on themselves and it's kind of run different places. They're usually dry. They don't look real moist anymore. They may have eschar present, which is that kind of whitish, fatty looking tissue. Minimal blanching. They're pretty painful usually still. And a lot of times we'll need to do some skin grafting to heal those or to close those wounds. So less than 2 and the elderly have disproportionately thin skin. That's why full thickness burns cause issues that wouldn't cause an issue. We wouldn't be burned nearly as badly. And then the other thing that I've learned with time is when it looks like this area is burned, they will not consider classifying that burn until 24 hours later if it's significant enough, because it is still burning the underlying tissue. And so while it looks like it's just here, it may actually be all of these areas once it's said and done after about 24 hours. So that's why they don't classify them at Riley until they're completely done kind of causing injury. These are full thickness, so this is when it extends through the epidermis and the dermis. It's into their sub-Q. They may have a leathery appearance. It may look like it's not very stretchy anymore. They're usually dry. They will not heal without skin grafting. Sometimes they don't heal at all. Just depends on the areas. A lot of times if these are over fingers and hands, they may lose fingertips and things just because of compromise to their circulation. And then 4th degree, this would be like firework injuries. We'll get these a lot where kids were holding a bottle rocket and it lights. 4th of July, we always have at least 4-finger Fred. One patient comes in, is what we call them. I hate to say it, but that's the truth. Trauma season also doesn't start at Riley until we've had our first lawnmower accident. So fun facts. These are burn or prolonged exposure to flames. They will usually do compartment pressures. So we have it's literally a needle on a stick that measures the pressure inside different compartments. So thighs, bellies, arms, in the muscle compartment, and they'll measure. And if it's a certain amount of pressure, then we will do escharotomies to kind of open that and release so that they can get blood flow still. And then these kiddos will need a wound closure of some sort or an amputation. Chemical burns, we're gonna brush off powder chemicals. Irrigate, except in certain ones. Just got to know our doc up there calls the solution to pollution dilution. That's the rhyme they use all the time. So make sure it drains away from the patient and away from you. So if you're washing the patient off, don't let it run down on you. Irrigate eyes with saline for at least 20 minutes. We use something called a Morgan lens. I'm sure they have them at CRH as well. It looks like a contact that has tubing effect that flows into it, and you put the contact in their eye and then hook up a bag of saline and you hang it above them and it literally just flushes their eyes. Depending on the age of the patient, they may need to be sedated for that. If you're uncertain about the chemical, the local poison center is a great help. And honestly, we use the poison center for any ingestion or any chemical exposure or whatever. Those people know their stuff. So do that, and then transferring to the burn center. Electrical burns. This was a kiddo we had who had dental work done. And the cord to whatever tool they were using was on her cheek, and they forgot to ground it, and it burnt her mouth in the corner. So there's all sorts of ways this can happen, but if you have an electrical burn to your lip, there is an artery that goes into your lip, the labial artery right here, and if the skin sloughs, it can expose that artery and you can have arterial bleeding secondary to the burn. So things just to kind of watch out for, especially if you're having to suction or anything. Just be gentle with those areas. Circumferential burns, so these are burns where they are burnt around a surface, so maybe an arm. Their chest cavity is one of our biggest areas of concern, because then obviously you can't ventilate them, right, if they can't expand their chest. Circumferential thorax injuries, like I said, a lot of times we'll do escharotomies. We will do these sometimes in the OR, a lot of times in the ER, just to get them opened up so that we can get them stabilized to get them upstairs if they're bad enough, because we won't be able to ventilate them, and we want to make sure we're preserving that end organ perfusion. These kiddos also, after they're burnt, will have a lot of like secondary kidney failure and things like that, just because of all the toxins and things, but also the blood flow just isn't there. So. And then these are child abuse. Unfortunately, this is another kiddo that was a dip, had an accident on themselves and got sat down in a hot bathtub. Cigarette burns, those are the little circular burns. Glove and stocking burns are what we call the ones where they're dipped, so it looks like they're wearing gloves or have like a sock or a pantyhose on. We need to know a hot iron. If they don't have splash or drip marks and it's a liquid burn, that's usually pretty indicative that there was some child abuse, or they had a secondary injury, like they fell, hit their head, knocked themselves unconscious, fell in a bathtub, and then the parents pulled them out. So there's different things that can happen. And like I said, very common during potty training. So what can you do to help them be more comfortable? So covering them with a sterile burn sheet or gauze, fentanyl, intranasal or IV, or some intranasal to get the IV and then continuing with the IV. That will help both of you, the patient and yourself. And then blisters, just leave them intact unless it's impeding like a joint motion. If there's a big blister and you can't get them positioned the way you need to, just drain, lance the blister, let it drain, and then go from there. We actually will usually leave, if they're quarter sized or smaller, we'll leave those blisters in place, because we call them a bio dressing. It's basically a way to keep an infection out. So, any questions on burns? Yeah.
When it comes to burns,
Yeah.
thermal burns, are we still getting it wet just to kind of cool it?
Just
Or
dry. Just dry. Anytime that you put water on a burn, it's literally, so with kids, this is my guiding principle. You want them warm, wet, and sticky. Every kid should be warm, wet, and sticky, right? So you want them to be normothermic, you want them to be hydrated, and you want them to have a normal blood glucose. So warm, wet, sticky. Those are the three most important things you can do for kiddos. So anything we can do, because their skin is thinner, to preserve that thermoregulation is important. So that's why we don't put anything cool on it anymore. And it will also cause vasoconstriction.
So is kind of the burn sheets gone out?
Like the gel burn sheets
Gel.
or whatever. Honestly, just dry gauze is what our burn docs would want. Yeah. Okay.
What about sticky?
So when they get to us, we will use some saline and get it wet so that we can peel it off without pulling the tissue underneath. Yeah.
What about ketamine for them?
Ketamine is fine as well. Yes, that does not have any
Have them disassociate.
negative. Yeah. If you have that, that's great too. The only other thing with ketamine though is using that, and then you may need to have like a secondary pain control along with it, because ketamine will make them out of it, but it doesn't do anything for their pain receptors. Okay, but yes, we do use that for dissociative pain control.
And even with the burn gel that we have, it's got the lidocaine in it.
We typically do not use anything like that on burns. Lidocaine does what? It'll numb it, but what is, yeah, it's causing vasoconstriction.
It also help keep the heat in
Yeah.
as well.
So we don't use anything, literally. Dry, sterile dressing is the best thing to do.
I used every bit of the burn gel out of every bag we had when I took over EMS. We had to carry those.
Patients love it. Water gel,
Yeah,
patients love those things.
they love it, but in the end, it's not beneficial to them. Now, if it's a small burn, Leroy, like you have a burn here or something, putting water or something like that on it in the long run is probably not going to do anything. But the guiding principle for our burn docs, Dr. Spera, who's the head of our burn team at Riley, would say just dry, sterile, covering it and keeping it the infection risk down.
I mean, because I know it's water soluble, yada yada.
I know, because if I burn myself, what's the first thing I do? Stick it right under the cold faucet, right? Because it feels better.
And I've seen people with older adults, that's what happens when you burnt their hand.
Mhm.
I don't remember if it's house fire or whatever, but in a lot of pain, but anyway,
Yeah, it feels better in the immediate, but in the long term, it delays their wound healing. Yeah. All right, we're gonna go through shock. Little review. So shock. Recognize its presence and respect it, okay? Especially in kiddos. You want to identify the probable cause because the different causes have different treatments, right? So we'll go through that a little bit to review. And then transfer to definitive care. And then always, always, always at the forefront, be thinking, could this be a form of shock? So these are our kind of 4 big ones. Hypovolemic, so we have hemorrhagic, your GI bleeds can have this, fluid loss. Kiddos who have been having vomiting and diarrhea, like significant vomiting and diarrhea for 24 hours or more, can be in hypovolemic shock pretty quickly, especially if it's large volumes and they're not able to retain anything. So just keeping that as a high index of suspicion. We always ask how many wet diapers or how many times have they urinated. They should be urinating or having a wet diaper every 6 to 8 hours a day. That is minimum. If parents say we've not had a wet diaper in 24 hours, they're already starting down that hypovolemic shock pathway. So asking diapers and things like that, because a lot of times kids can go 24 hours without drinking a whole lot and still have pretty good perfusion, right? But asking just to kind of go through that. And then the other thing that I'll hear a lot of parents is, oh, well, they're drinking, okay, but they're not eating anything. Okay, well, when my stomach's upset, I don't want to eat either, but we want them to be drinking liquids, okay? Sweating, so if someone's been out in the sun or working out in the yard or something like that, especially older people, they can get hypovolemic shock just from all of the fluid loss that they have. Asthmatics who are having an asthmatic flare can also have that insensible loss from breathing like a freight train for so long. So just keeping all of those things in mind. Obstructive shock, so these are your pneumothorax, your PEs, your pericardial tamponade. Some things you can fix in the field, some things you can't. Needle decompression, getting them to an ER quickly if they have a PE especially, lots of oxygen, keeping them sitting upright. Cardiogenic shock, so an MI, any arrhythmias, valve failures, toxins, and then an iatrogenic or a drug-related cardiogenic shock. We used to get, I haven't had any in a long time, but when I worked at Methodist, we would get kids that did baggy parties. And so they would literally go to like grandma's house or someone's house and they would steal meds that they thought were pain meds or drugs that were going to get them high. They would all bring them to a friend's house, throw them in a baggie, and then everybody would take a handful and see what they got. And so we had a kid one time that took a whole handful of beta blockers and, well, guess what? Didn't get him high. Got his heart rate roll low. Distributive, anaphylaxis. How many systems have to be involved for you guys to consider an anaphylactic reaction?
1, 2.
2 or more. So if they have a rash, if they are having some stridor, if they're wheezing, if they're vomiting, any of those things, if there are 2 or more systems involved, treat it as though it's anaphylaxis, even if they well at that moment, okay? Epi, Benadryl, all the things. Septic shock. So these are our friends who maybe have been sick for a while. Maybe they've had a bowel perf and they didn't realize it. Our fever neutropenia patients, so our immunocompromised friends, all of those kids. And then neurogenic shock, which that one is difficult. So that's a lot of times our spinal cord injuries and things like that, they can be all over the place. So at that point, it's a matter of treating symptoms. So hypovolemic, these are just some of the reasons this can happen. We talked about, so if they're having tenting, if they are mottled skin, if they have cool extremities, their cap refill. Kids, cap refill is a great way to look at their perfusion because sometimes they look mottled, but even with the mottled area, if you push on it and their cap refill is 4 or less, 3 or less would be ideal, 2 or less would be perfect. You can kind of gauge that. The other thing that's nice with that is you can do it before you start your fluid bolus and then start doing it in between your fluid boluses or during your fluid boluses, and a lot of times you'll see them pink up. If you have a baby who you need to give a fluid bolus to, use 10 ml flushes and just hand push that bolus. If it's, you know, a 4 kilo or a 8 kilo kid and you're doing 20 per kilo, doesn't take but, you know, a few normal saline boluses to do that rather than hanging fluids. Plus, then you can watch the IV really close too. Tachycardia and hypotension are late signs, especially hypotension. So you don't want to wait until they don't have a blood pressure left, because that's usually not going to come back quickly. This is your basic physiology of blood pressure. So you guys know you've got your preload, which is the the amount of blood you're putting in or you're pushing against to get in. Afterload is what it's pushing against, and it's the force at which it's coming out, and then the contractility of your heart, how well it's able to contract. So your cardiac output is your stroke volume times your heart rate, just so that you guys have the physiology of that in mind. For pediatrics, blood volumes, neonates have 85 to 90 mils of blood. If you think about it, that's not much blood, right? So be judicious with your blood samples if you're taking them. Infants are 75 to 80. Children are 70 to 75 mils per kg. Male adolescents, 70 mils per kg, and then female, 65. But as it gets more kgs, obviously, then more blood. Volume resuscitation, so we're going to use vascular access, normal saline or lactated ringers. If they have blood loss, though, like there's a trauma and they're in a pool of blood, the fluid is probably not going to help a whole bunch, right? It's going to cause hemodilution. So the best thing to do is to stop the bleeding, and then if you have blood, give them blood, or get them to the closest facility that has blood, and then oxygenate, because they're not going to be able to oxygenate real well. 20 mils per kg over 5 minutes. Reassess after that, and then do another one if you need another one. We want to get 60 mils per kg in the first 20 to 60 minutes if they're in shock. But we need to reassess and assess their lung sounds in between all of those. This is our trauma triad of death. Just going through this. Again, this is our warm, wet, sticky thing. So coagulopathy, acidosis, and hypothermia. So we want to keep them warm or normothermic. We want to make sure that they are wet and they don't have coagulation or thinner or thicker blood going on. And then we want their glucose and all of their pH and everything to be normal. So that's your, if you take nothing from this, warm, wet, sticky. Kids are warm, wet, and sticky most of the time anyway. So cardiogenic shock. So these would be our blunt cardiac injuries. So like hitting the steering wheel, or the kid that falls and lands like right on their chest. Things like that, gets hit in the chest with the baseball, can cause arrhythmias, but also can cause issues to their chest. They can get JVD, you'll see that. You'll hear like a murmur or a weird heart sound is the best way I can put that sometimes. Respiratory distress, late in the game it's peripheral edema, and you're gonna just give them supportive care. And then these are the kiddos that will start like milrinone or a pressor on that's aimed at their cardiac function. Obstructive shock, so these are our PE, our cardiac tamponade or our PE kiddo. So distended neck veins, hypotension, like muffled heart sounds, respiratory distress, and then tension pneumothorax would be like you can't hear breath sounds on one side, you need to needle decompress, things like that, okay? If you guys do a needle decompression, you can do a needle decompression, and if it's something you're concerned is gonna recur, put a stopcock on the end of it, and then you can leave that catheter in place, close the stopcock off to that, and then open it every once in a while, and it will re-decompress. So treatment, we talked about this. For cardiac tamponade, it's a pericardiocentesis, which we don't do in the ER very often, so I would wager a bet that you won't be doing that in the field. Thrombolytic therapy, we do have kids that have PEs, but also like IVC clots and things in different areas, and they all go on heparin drips or thrombolytic therapy long term. And then tension pneumothorax, needle decompression, and long-term solution for that is a chest tube. Tall, skinny teenage males are at a higher risk for having tension pneumothorax. For whatever reason, they'll have lung collapse a lot more easily. So if you have a kiddo that's having trouble breathing and he's really, really, really tall and thin, listen to your breath sounds really well. We'll get them, and sometimes they will come in and they've had them 2 or 3 times, and they'll actually go in and pin or stitch their lung tissue to their wall to help prevent that from happening repeatedly. Distributive shock. This is an inappropriate vasodilation and pooling of blood in the peripheral. So there's no change in their blood. They have the same amount of blood volume, but it's third spacing and it's pooling. So it's like they have the pipes that are the appropriate size, but they don't have the fluid in the pipes to keep the blood pressure up. These kiddos almost always will need pressors. Anaphylactic shock, we need to get that fluid to third spacing, so that's where the epi comes in, that's where your Benadryl will come in, things like that. And then septic shock, we will give IV antibiotics, which initially may actually worsen it. There's something called lysing syndrome. So for especially our hemonc kiddos, if they are having an infection, they have all of the bacteria floating around in their bloodstream. When you give them their first dose of IV antibiotics, it causes all of those endotoxins to get released into their bloodstream. They go downhill, but then we'll get them back with pressors and things. We've already talked about this for the most part. I'm not going to bore you with that. Any questions over shock? Okay. Maltreatment and human trafficking, we're going to go through this. Unfortunately, 13.6 per 1,000 kiddos were victims of maltreatment. This is the 2021 statistics. We're at 2026, and this number has just continued to grow. I just don't have those statistics available. It's the 11th highest rate in the country. So we're known for something, again, that's not great. We're also all fat, if you didn't know that. Human trafficking in Indiana. We have a huge problem with this. It happens a lot around like when the Super Bowl was here, we had a lot of human trafficking. The Indy 500 when it's in town, the NBA stuff when we have like the combine and stuff like that. Anytime there's a large influx of adult men into the area, we have an increase in our human trafficking, unfortunately. So we see more of it during large events. Like I said, the Big Ten events, Indy 500, all of those things. If they come in and they have injuries that are non-accidental or inconsistent, we need to make sure that we are kind of looking at the history and things like that. And then we'll kind of go through the different types of abuse here just to go through. So just for definitive reasons, child maltreatment is when the caregiver or parent abuses or neglects their child under 18 years of age. You also can have adult maltreatment or like elder abuse that can happen as well, or we will have adult maltreatment for like mentally or physically handicapped adults that are being cared for by other caregivers. Human trafficking is when an individual is exploited. They may have been forced into it, they may have been coerced into it. We'll get teenage girls in who are being trafficked, and if we don't take them into physical police custody, they will go right back to their trafficker because unfortunately they didn't have a great childhood, and this person shows them love. Despite the fact they're making them do heinous acts, they're at least getting someone that's taking care of them. And then labor or sex work. It doesn't always have to be sexually related. It can also be labor related. A non-accidental physical injury that's caused by an individual who has responsibility for the child, that would be physical abuse. That can be a parent, that can be a caregiver, that can be daycare, that can be mom's boyfriend, that can be, dad's girlfriend, whatever. Human trafficking, we just talked about. Sexual abuse is non-consensual or inappropriate sexual activity. A lot of times we'll have kids that are like inappropriately sexual towards another person or make comments or are way overly friendly. And I'm not talking about just my kids are friendly, but way inappropriately friendly. Those are all kind of red flags that we'll see for some of this stuff. If they've started soiling themselves or having accidents and they have no history of that, that can be a sign of it. Complaining of chronic like belly pain or it hurts when I pee or things like that, those are also all signs. Neglect is when they fail to provide for basic needs of food, clothing, shelter. Supervision, we'll get kids who wander out and are just wandering around a neighborhood in a diaper because the parents left them at home with a 8-year-old sibling or something, and the 2-year-old is off wandering. And so that, again, would be neglect. Mental health, and then we'll have kids that come in and it is like their mouth is black. We call it bottle rot. And it's where the parents are not brushing their teeth or things like that, but that causes significant health injuries. and can also cause cardiac issues. And then emotional or psychological abuse. I'm sure both of my kids would tell you I'm emotionally abusive at times too, but these are things that are going to impair their emotional development and their self-worth as they get older. So risk factors for abusing a child would be the biggest issue is if you were abused yourself, it can cause an increase in having them abuse as well. Mental illness, single parents with minimal support, you can appreciate that that would be difficult. Substance abuse, multiple dependent children, lower income or a lower level of education, they're having trouble supporting themselves, things like that. And then inadequate parenting knowledge. Sometimes they just don't know. They weren't shown how to raise their children, and so they're just winging it. And then risk factors for experiencing abuse. If they're less than 1 year of age, that's a big risk factor. And then any kiddo that has a disability, that's a big risk factor as well. So signs that you guys can look for if you have patients. So unexplained injuries. So the injury pattern does not match what the parent told you happened, or you're there for something else and you notice that like the whole back of their ear is black, or they have a weird linear or patterned bruise when you lift up their shirt to look at their breathing because they're having an asthma exacerbation, things like that. There is something called Mongolian spots. Are you guys familiar with what Mongolian spots are? So it's especially in our Hakachin population, our Burmese population, African American, usually it's a darker skin tone, and it looks almost purpley bruised. A lot of times it's on their buttocks or their upper thighs or their back, and it's just a birth. It's their normal. They've probably had it for a long time. A lot of times I'll just ask the parent like, oh, hey mom, is this skin color normal for them? Is this their, normal? No, oh yeah, that's their birthmark. They've had it since they were born. And then we know that it's probably not something different, but just be aware of that. Belt marks, looped cords, a hanger. I had a kid that got beaten with a hanger really bad. So he had like V-shaped lines on him. If the kiddo reports the caregiver injured them, or if they're scared when the caregiver is present. That, however, is not always the case, because we will have kids that were abused badly, but they still want their mom when it comes down to it. So that one is sometimes not. Emotional and psychological abuse. We have this for a lot of our kiddos who are there for SI or behavioral issues. They might be depressed. They may have delayed physical development. They might not be at a appropriate developmental level. We had kids that were found in a hotel one time, and one of them was almost a year old and could not sit up on their own because they had just been left in a crib. And so they had not developed the ability to do those things. Delayed emotional development, and then behavioral extremes if they act out or have no reaction, that can be concerning as well. Sexual abuse, STIs, so we'll get 3-year-olds that have gonorrhea and chlamydia, and guess what? You don't just get that off a toilet seat. So STIs, pregnancies, 12 or 11-year-old girl that's pregnant usually was not a consensual thing, sometimes, but usually not. Genitalia injuries, especially like tears, rectal tears, and I'm not talking about just like fissures from being chronically constipated. I'm talking about actual like degrees of tears. Trouble sitting, trouble walking, like I said, having accidents when they didn't used to, if they're fearful, clingy, withdrawing socially, things like that. That quick attachment to strangers or new adults. Or sometimes they'll just outright tell you. Neglect, so if they're dirty, I have a 6-year-old who has dirt under his fingernails at all times. I just think that's because he has fun. I'm talking about like, we're filthy. We smell. We are have a big swollen belly and skinny little arms and legs. We'll have that sometimes, especially if you have a child who's feeding tube or a G-tube dependent kiddo and they're not getting fed regularly or on schedule. A lot of times they'll have, we call it the bloat, which is a big swollen belly and underdeveloped arms and legs. Lack of dental care, medical care, lack of clothing. They'll be the ones that we find in the wintertime out in the street, and they're wearing you know, flip-flops and shorts and a t-shirt, kind of those things. We also have injuries as a result of inadequate supervision, like we'll have kids that get hit by a car or burn themselves or things like that because there just wasn't an adult present. So all of those things. Drug and alcohol abuse as a way to kind of escape, especially as they get older. And then reports of no one providing care at home. So those are kind of the big things there. Sentinel injuries, this is just a legal definition. These are warning signs that there's some physical abuse happening. They're in our pre-cruising infants. So like a 1-year-old who's walking, you wouldn't be altogether surprised if they have like a bump on their head or something because they fell and hit their head, or they have bruises on their shins or their knees from where they fell, stuff like that. But if you have a 6-month-old that has a bruise on their head, there needs to be a pretty plausible explanation as to how that got there, right? So sentinel injuries are things. The reason that every kiddo that comes to the ER at Riley has to be completely exposed and gets a gown is because we've had kiddos who have come in for other random things, and then we get them 3 weeks later and they are now a trauma 1 and a non-accidental trauma. Because if you don't expose, you don't necessarily catch those little sentinel injuries or the things that could have been a warning sign to help us know that something was happening. Intraoral injuries, frenula tears, so the little thing that connects your lip here and here, if those are torn, those are also, parents will put their hands over their face or put a pillow or something over their face and they're fighting like this and it will tear their frenula. So that is another sign of child abuse. And then anytime they have like a subconjunctival hemorrhage, so like the reddened part around their eyes and things, they may have bleeding in their retina. So like I said, we want to look for these and assist with that early identification. So even just doing a really good head-to-toe assessment. If you don't have a gown to put them in and you can't strip them, like looking under their shirt, looking under the legs of their pants or their sleeper, take them out of their onesie and then just keep them warm because kiddos do get cold a lot faster. So we're going to do a couple of little case studies here. So on December 18th, a 1-year-old female presents to the emergency room with her mom and older sibling for Trauma 1 services. When providing the patient's history, the mother explains that her 2 daughters were playing in the bathtub when she heard a scream. She states that she entered the bathroom after hearing the scream and saw the patient face down in the water. Mom removed the patient from the bathtub and called 911, trying to wake her up after 10 minutes. Of note, the older sibling appears dirty and is wearing shorts and a short-sleeved t-shirt. As the nurse or medic, the history provided by the mom in your assessment leads you to suspect which of the following. What do you guys think? And there can be more than one. B, neglect, right? Absolutely. All of those things, because if mom didn't get her awake, if my kid was underwater in a bathtub, probably wouldn't wait 10 minutes to call, right? We're, in December, and we're wearing short sleeves and a short sleeve t-shirt. If they've left the house anytime recently, I shouldn't have been in that. All of those things, right? And then the mom wasn't in the bathroom. Mom should be in the bathroom anytime you have a kiddo that's little. So yes. As you wait for the attending physician to arrive to the room, you hear mom talking on the phone in the hallway. You hear the mom say, "I cannot believe this happened. I always leave the kids in the bathtub by themselves." What should you document as part of your run on that narrative? Which one? Yeah, C. So anytime you can document in quotations exact words of the parents, that's going to be ideal. Hearsay is when you document it, but it's not the parents' exact words. That leaves open room for interpretation, and it usually gets thrown out in court. If you can put exact words of the parents in, that is usually more, it will stand up in court better. So appropriate documentation. And you never want to document anything that makes it sound like judging. Mom seemed upset as she was talking on the phone. Well, was she actually upset, or was she, I was trying to think, Dari, Middle Eastern, sometimes they will talk to you and it sounds like they're screaming at you, but it's actually just the volume and the tone that they use when they talk to you. So it can leave room for interpretation. So some different types of human trafficking. We talked about this a little bit. Labor trafficking. So that's when the kiddo is being, third world countries or other countries, they might be forced into the military at a young age because there's not enough adults, or like over in the Middle East, you'll see the kids carrying the huge guns on the news and things like that. So child soldiers. Labor, domestic servitude, paying off a debt. We will have kiddos who get brought in and they, as it turns out, their parents sent them over to live with a cousin because the parents couldn't afford to get everybody to America, but they thought they were doing the best for their child and sent them over here to live with this cousin that was actually a cousin. However, the cousin used the child then for things that were not positive. They're using them as a moneymaker. So those are things, or they're using that to get the parents money to get here. Sex trafficking occurs when they're forced to engage in commercial sex. It can be pornography, it can be prostitution, it can be all of those things. Mail order brides that are children sometimes can be acquired as well, where they don't have appropriate birth certificates or their papers are falsified to get younger kids over here. And then harvesting of organs in other countries, they will actually do this. And if there's a whole black market for organs, if you didn't know that, look it up sometime. Big eye opener. Forced involvement in criminal acts or begging. We just got back from vacation, and in a lot of other foreign countries, like the mom will be there begging, and then there'll be kids while mom is begging and has your attention. Her kids are now running around and fleecing everybody around you's pockets. So they'll do things like that, or illegal adoptions where they force parents to give up their child in another country and then sell it to someone who's wanting a baby. So all of these things are human trafficking. Things that you guys can watch for. So pregnancy when it isn't an anticipated pregnancy, right? Tattoos, they will mark them sometimes. So if they have a very unusual tattoo or like a number or even, like a symbol, usually somewhere where it's not super visible, that can be a sign. Anogenital trauma, those are things that can, because they will be forced to put things in their mouth or other areas and they don't want to, and it'll cause an injury by the force. They may self-injure themselves as a way to get taken to the hospital to get help or to get out of that situation or to not have to do what they are supposed to be doing that day. Running away, homelessness is a big one. We'll have teenage girls who kind of get picked up by a pimp, or they run away and then this guy swoops in and buys them new clothes and gets them nails and gets their hair and is their friend, and then suddenly we have a reason that we have to pay back this gentleman. Exhaustion, they may be up, not sleeping, not having a safe place to sleep, things like that. Ownership of expensive items or large quantities of money. We had a teenage girl who came in and who had like a wad of cash in a Gucci purse that I'm guessing the Gucci purse was probably actually Gucci purse, and it was a prostitution situation. She was 14. So things like that. They'll come in maybe with an accompanying individual, and you'll ask them a question, and they'll say, they won't say anything, or they'll be like, he can explain it better, or he'll talk over her, or won't let her go in the room by herself to get vitals done, or we go to x-ray to look for an injury and he insists that he's coming as well because she'll get scared. Things like that are all, if you are transporting them, they may not want the child transported by themselves, things like that, okay? What contributes to making it difficult? So individuals experiencing, they may be fearful of consequences from their trafficker, especially like if they're doing it because they're trying to get their family here from another country, or they think their parents are also employed by the same person, and if they don't do what the man is telling them, their parents may be fired and then they would experience homelessness. There's all sorts of mind games that they will play. They might get deported, they might go back to their previous living situation, different things like that. And then language barriers, right? A lot of the kids' situations we have with younger kids, they might not speak good English. They were sent over here and then they'd never learned English or didn't learn the language. So all of those things can be. And then also, if they had a poor home life and they now have at least a warm place, they get some new things once in a while, and this person cares about them, they may not want to say anything that will get that person in trouble because they don't want to have to go back to their mom or dad. If you guys are ever concerned, it is well within your wheelhouse to report. This is the Indiana Child Abuse and Neglect Hotline or the National Human Trafficking Hotline. You can absolutely make an anonymous report. You do not have to give your name or any of your information. I know Jeff will go on runs, and he said that sometimes you guys go into houses. We all have done it, gone into a house, and you look around and you think, how does a child live in this situation? Or there may not be, you know, a safe place for them to sleep, or you're looking and there's like a dirty mattress and that's it, and they have an infant. All of those are situations where this is something that you can do. You may be powerless to make it better for them, but you can at least report it so DCS can investigate and check it out. I will be the first to admit that DCS needs a big overhaul in our state.
I was getting ready to ask that. If
But
CPS
at
can
least-
help you, where can you go?
At least getting an awareness and repeating each time you go, if you're there, is not something that you should, it's something you should think about doing. Any questions over child abuse, neglect, things like that? All right. So these are some things that are pediatric tips and tricks that you guys can use. The Simply Sayin app, it's over here. It's a free app. You can put it on your phone. It's great. It will go through and it gives like medical illustrations to the kids. It gives you language to use. Like when I put in an IV, I'm giving them a straw. I'm just gonna give them a straw. We're gonna use a magic straw to give your veins a drink, is how we talk about that. When I take a kid's blood pressure, I don't ever take their blood pressure. I'm gonna see how big your muscles are, and or give your arm a hug, things like that. Making it child-friendly language will get it a whole lot further. The pulse ox, you know, when I was younger, I would have understood what an ET finger is. Kids now do not understand what that means. But just saying like, I'm gonna make your finger a magic wand or things like that, putting your finger in the pulse ox first and then having them do theirs, things like that. Getting down on their level or sitting down on the ground with them when you're assessing or doing things is helpful, because then you're not towering over the top of them. I will just say that when we go out in public, kids respond more appropriately to me than they do Jeff, because Jeff's huge and scary and I'm kid-sized. So just getting down on their level and doing that. Cervical collars, we talk about that being a necklace instead of a cervical collar, so that it's I'm gonna give you a soft necklace to keep your head and neck safe. EKG leads, they're stickers, we talk about that. Tiny plastic straws. Medication, I'm going to give you something to drink that's going to make your body feel better, or I'm going to give you something that's going to make your body feel better. Tourniquet, when you put on, I'm going to give your arm a really, really tight hug with my magic rubber band or something like that. Do not ever lie to a child. If they say, will that hurt? It's gonna feel like a bee sting, or it will hurt, but only for a second, or it's going to hurt a little bit, but I need you, or but here's something you can do to help, or I have a job for you to do while we're doing this. Different things that you can do to kind of talk to them. Veins, I always talk to them about their blue lines. Help me find your blue lines. You can do that when you're finding IVs. I also, on my badge, have an IV catheter that has the needle taken out, just so they can see that it's just a plastic flexible, because a lot of times they feel better about it if they don't see a needle in it. Little things like that. And then sometimes it's just a matter of you're just gonna have to kind of help them. Comfort positioning is another thing, or comfort holds. If you have parents that are there that are willing to help, sitting them on their parents' lap and having them give them a bear hug and then fold a leg over their legs will help them hold the kiddos still. They're not holding them down. They're just comforting them while they are getting their IV placed or while you're putting a splint on or whatever. Splinting is super helpful if they have a fracture. Intranasal fentanyl is man's best friend for these kiddos. Use that frequently as well. Give them choices anytime you can, even if there really isn't a choice. Like, we're gonna put our straw in and we're gonna find a blue line and we're gonna put a straw in. Do you want me to count to 3 or do you want me to count to 4? Giving them choices where we're gonna have to do this, you don't have a choice, but giving them a choice. But the Simply Say an app is super helpful. So look that up if you want. This is Nicole Hall. She is our EMS liaison at Riley. So if you guys ever have a run that you know gets flown to Riley or that you bring up and drop off at Riley, you can email her and she can give you like what the injuries were or what the outcome was or different things like that. She also will reach out to services if we see like an education need on a certain thing or a certain run. She may reach out as well. And do some education for that. She can also, along with myself, get you hooked up with like PCOM or different people like that to come down and do education. Any questions?
But he's awful quiet.
I know. Always get a hold of me. If you come to Riley, look me up. I'm in the ER. I love seeing people I actually know at work. It's fun. It makes the days a little better.
Text her and see if she's working.
Yes, send me a text and say, hey, are you there? But yeah, and then if you guys ever have a negative interaction with someone in the ER at Riley, I would love to know about it because that's not how we operate. So seeing a look, so we can chat afterwards. But it's not what we want. But also do keep in mind that we do have some younger nurses. I'm sure you guys all know on the medical side of things that there are people driving ambulances and fire trucks now that look like they're 12. We have nurses that are about that same age. So give them some grace as well because they may just be super busy and overwhelmed. But if you have a negative, I would like to be able to at least do some in the moment service recovery for that. So, all right.
Thank you, Jenny.
That's all I got. Thanks, guys. Oh, and I brought goodies. I did bring goodies. So come on up if you want to grab some. I think I have cups and I have little backpacks.
The lights are gonna come on.
These things are great.
Come back a little bit, you're too close. See that line right there? Touch the yellow.
Sam's watching.
I
Send it to the link.
It's easier.
How are you?
Much easier.
Good. Grab a coffee cup.
Ooh, I would love a coffee cup.
I don't want to have to take them back.
Coffee cup, yeah.
Thank you.
Yeah, you're welcome.
Thank you.
Got a bunch.
I've sewn mine back together.
Ooh, that's a good one, too.
Yeah.
I wasn't we're getting friends.
Ooh, the bottom, it's a rubber instead of an actual cork.
Isn't that nice?
That's real nice,
Hi,
yeah.
Fred Daphne.
I'm like, oh, I'm glad you came back.
Yeah.
I can't, I need
wanted to
one
be
of
here for the
them.
whole thing.
Frank finds me the
What
funniest
truck you on?
shirts.
That is
He
funny.
he's got one that says, I know it's stupid, but I can
Perhaps.
sedate it.
Yep.
Yes,
I've
ma'am.
had some personal stuff come up that I need to leave early next week. Are you okay if I leave early?
Yeah, I have.
Retirement, one day closer.
You'll be here
I'm
then.
actually-
A key now.
Saying the same thing.
No, I'm
Oh,
actually-
well, I've always had Tim here to make sure
Yeah.
that,
I stole it from Daryl. I'm gonna take it to like Lowe's today and get it one made so I can have one for.
well, I'm gonna be here.
Yeah.
I just need to leave early.
You're fine. Yeah, you're fine. I can just turn the lights off, close the door. No problem for me. I got you.
I figured you would.
Yep.
I didn't, and it came up last week, and I was like, they were like, can you, and I said, let me get, you had that backpack on.
I know.
Did you get one of these?
I got one. I don't need.
Wait, it's still playing audio?
Oh,